comment box here.
Fine. Hello everyone. So first of all, happy Christmas every day. Hi everyone, and chalo, let us start with this YouTube session, and we are starting with the F.I.R session, final intensive revision session today. And now we will be starting with, and am I audible and visible? Just tell me if I'm audible or not. So chalo, let us start today. And in this F.I.R session or final intensive revision session, we will be revising the most important topics, right? And most of the important previously asked topics will be covered, each subject wise. So you need not worry. And even if you do this, most of your topics will be covered and you will be able to clear your exam very easily. And yes, more than enough. Most of the asked, when you will, after we finish the session, you will see the notes. In the notes, most of the important topics, important asked have been covered. We have tried to cover everything conceptually and most of the images, so it will be covering. And not only that, surgery, we will also integrate other subjects as well. Jitna ho sakega utna, and all subjects we will integrate. So let us start, right guys? Chalo, so we'll be starting now. So for surgery, before starting, I would prefer ki we start from some important topics. So should we start from, let us go in the sequence wise only. So or before that, we will start from the important topic, that is the breast. So now let us start from important topic, that is breast. Most of the questions in surgery, almost every topic will be covered. Every topic, whatever in the last 5 years they've asked, most of the topics we will be covering. Nothing will be left. PDF will be provided on the Telegram group. No, don't worry. Now we will be starting here. So with the breast, come on. So first topic is we are going to discuss is mastitis, right? Most common cause is Staph aureus infection, right? From the baby's mouth or the cracked nipples, it can happen, right? The clinical features, what they will give you features of redness, swelling, or increased temperature, right? Now, if there is development of abscess in the late stage due to mastitis, then there will be fluctuation sign present, right? Diagnosis will be via the USG. For mastitis, the treatment will be antibiotics. Suppose if the pus becomes present and if it progresses to breast abscess, then what will you do? If breast abscess is done, then on examination you will find fluctuation test will be positive, tenderness will be there, right? And in the question they will give you history of breast pain, and there will be history of engorged breast as well as high fever and chills, right? If there is abscess, what management will you do? You will just do incision and drainage, right? Or if multiple options are given, then your first choice will be repeated aspiration under the USG with antibiotics. If this is not in the option, then the second preferred option will be incision and drainage and no feeding from the infected breast. Okay guys, chalo. Now just have a look. If they give you in the image, what images have they given you? You can see in the USG of the breast they have given. Now in the image they will give you, this is the mastitis. You can see the red inflamed and engorged breast. You can see here, compare it, right? Now coming here to one more breast lesion they have asked is fibroadenoma. So fibroadenoma, what is it? It is a benign lesion first of all, right? Now it is due to hyperplasia of the intralobular stroma of the breast. Age group is very important. When they give you fibroadenoma, the age group is very important. You will have to notice younger age group female. That means in the between the age of 15 to 25 years, more commonly also called as breast mouse. Why breast mouse? When you will analyze the lesion, examine the lesion, it will feel like it is running away, hypermobile, moving from one place to the other, right? Now, fibroadenoma, you have discussed, arises from the lobules, right? If the fibroadenoma is more than 5 centimeter size, it is giant fibroadenoma. Okay. Now, what will the clinical features they will give you in the question? They will give you the lesion is hypermobile, it is painless in nature, and it is a lumpy lesion in the breast, right? Now, when you move forward, what will you see? So for the investigations, they have asked you question regarding the investigation. First of all, they will give you the age group, 15 to 25 years age group, hypermobile, painless lump in the breast, that is moving from one place to another on examination. Another investigation they will ask you is USG. Why USG? Under 40 years of age, you already know, or 35, less than 35 years of age female, the breast tissue is dense. So you do not perform mammography. You perform the USG is the diagnosis of choice there, right? If the female is more than 40 or more than 35 years of age, then you can go for mammography. In mammography, what will you see? You will see there is popcorn calcification seen, right? Investigation of choice will be FNAC, that is fine needle aspiration technique. Now, what will the treatment? For treatment, the better option or answer in fibroadenoma will be enucleation, right? If enucleation is not given, then you can also write excision, right? Now, look at the radiology part. They will give you the scan and they will ask you like this. Okay? So just you can see here the popcorn calcifications seen in the mammography in the fibroadenoma. Here also you can see fibroadenoma appearing as a white dense lesion or nodule or lump in the breast tissue, right? Now, one more tumor they have asked you, and they have asked you many times from the breast, is Phyllodes tumor. They will give you the image like this, see. And what happens in Phyllodes tumor? It is due to hyperplasia of the stroma. Now, again, age group is very important. Compare. In fibroadenoma, I told you in 15 to 25 years of age group female, right? Hypermobile lump, painless lump. In Phyllodes tumor, what is happening? Here also, the lump is painless, right? But it will be enlarged, engorged lump. Look at the image like this. No differentiation, enlarged, engorged lump. Painless lump, but the age group is important here. Age group is more than 40 years of female they will give you, right? Now, here, the lump will be rapidly progressive in size, okay? And first choice of investigation here again will be USG. Then investigation of choice, the preferred investigation, IOC, will be true cut biopsy, right? And in histology, in pathology part, they will give you the slide and they will ask you what is the appearance of the slide. So in this, the appearance will be leaf-like appearance in microscopy is seen. Okay, guys? So you can see here leaf-like appearance in the microscopy that can be seen. Done. Now, come here. Another topic that they have asked you is breast carcinoma. So most common invasive ductal carcinoma type they will ask you, that is invasive ductal carcinoma. Now, it is itself a type of adenocarcinoma. So, in the option, if they have given you most common type of carcinoma, that will be adenocarcinoma. If they give you in the option, this is also correct. If they ask you invasive ductal carcinoma, this is also correct. But your preferred answer will be invasive ductal carcinoma. Why? Because invasive ductal carcinoma is itself a type of adenocarcinoma. Okay. So, now, what is the most common site of the breast carcinoma? They have asked you. This is also an asked question, that is upper outer quadrant of the breast. Fine. Now, genetic association they have asked you. In females, both BRCA1 and BRCA2, right? In males, only BRCA2 is associated, right? More commonly. Now, TNM staging they have asked a lot number of times, but for the short revision, I will tell you, because we have less time right now. We cannot discuss entire TNM staging. So for those people who do not want to remember and who feel like you cannot remember every of the TNM staging, you can go with the short trick. What is the short trick? Most of the times they have asked you T4B. And what is T4B? They will give you about the PUD orange appearance. So this will be the image they will give you, right? PUD orange appearance, and the staging will also always be T4B. And why does it happen? It happens due to blockade of subdermal, below the dermis, subdermal superficial lymphatics. When they are blocked, it will give appearance of PUD orange, right? T4D. Now, come here. For staging, the investigation of choice will always be MRI, right? Now, distant metastasis, you already know, it will be PET scan, and treatment, most commonly modified radical mastectomy is the process that you will be performing. Now, come here to the next topic. Sometimes they have asked you the difference between simple mastectomy, radical mastectomy, and modified radical mastectomy. Mostly what they have asked you, how many levels of lymph nodes will be resected or removed in radical mastectomy. This is an asked question. So in this notes, you can see every topic conceptually and everything we have covered. So just be confident, just be with us, bear with us, and we will be revising. In simple mastectomy, what we are going to do? We are going to remove the nipple, the areola, and the breast tissue. Only breast is removed. In radical mastectomy, along with simple mastectomy, you are removing lymph nodes. lymph nodes up to 1, 2 and 3, level 1, 2 and 3 nodes. Done. This they have asked question. This is an asked question, right? Along with that, muscles, pectoralis major and pectoralis minor. Done in radical mastectomy. Nowadays, more commonly performed procedure is modified radical mastectomy. They have asked you the difference. So what is the difference here? In modified radical mastectomy, you are not only doing simple mastectomy, plus you are removing the lymph nodes up to 1, 2 and 3 level. Apart from that, you are removing the pectoralis fascia only, and not removing the pectoralis major and minor muscles. ठीक है? In radical mastectomy, you were removing the pectoralis major and minor muscles, whereas in modified radical mastectomy, you are just removing the pectoralis fascia. Important question point. Difference. I hope you can understand and remember. Now, moving ahead. Structures preserved in the MRM. This is also an asked question. What are the structures that are preserved in modified radical mastectomy? So you can remember by A, B, C and D. A is your axillary vein, B is your Bell's nerve, C is your cephalic vein, and D is nerve to latissimus dorsi. Done. Now, come here. Complication associated with MRM, modified radical mastectomy. They have asked you one more topic, that is seroma, most common complication. Apart from that, there is winging of scapula, one of the common complications. Lymph edema is also one of the common complications, you know. And flap necrosis in breast radical mastectomy. You cannot, or when you do mastectomy, you cannot leave the wound open. You just put a flap, right? And if you put the flap, there is risk of the flap necrosis also involved, right? Now, structures removed, you have seen. Now, Stewart-Travis syndrome or lymphangiosarcoma, this is a late complication of associated with MRM, modified radical mastectomy. Lymphangiosarcoma also a late complication of MRM. Coming here to the topic called as duct papilloma. See, now duct papilloma and duct ectasia, they are basically same things. Difference is in duct papilloma, one duct is involved, and in duct ectasia, multiple ducts are involved, right? Another differentiating point in the question, how will you differentiate? I will tell you. In duct papilloma, generally one duct is involved, and they will give you in history of bloody discharge. Bloody discharge of history will be given, right? So here the investigation of choice will be ductography showing filling defect. Now in treatment, what you will do? You will do microdocectomy. Done. But in duct ectasia, they will generally give you more than 40 years of female. Along with that, they will give you multiple irregular dilated ducts. I told you multiple ducts will be involved. Apart from that, this will be associated with history of chronic mastitis. Now, the most important differentiating point, greenish discharge from the nipples. If they give you greenish discharge from the nipples, or they give you greenish blackish discharge from the nipples, go with duct ectasia. Multiple ducts are involved, right? Investigation of choice, again same, ductography, and treatment is Hadfield surgery. Hadfield surgery, it is nothing. It is just the conical excision of all the ducts. Now, come here. Somebody was asking mastitis and abscess में difference कैसे करेंगे? Mihir Pant, yes, we have already discussed, Dr. Mihir, I told you, mastitis and abscess. What will happen if there will be presence of mastitis develops into abscess? Then there will be fluctuation, test positive, and tenderness will be present. It will increase. I already discussed that. See, fluctuation will become positive. Why? Because it is breast is filled with the pus. So whenever you will do fluctuation test will come positive. Now, come here. Coming to testis. You have the questions from the testis, what they have asked. In questions of testis, they have asked about one descended testis, right? So most common congenital anomaly of male genitalia, one thing. Again, one thing is, in undescended testis, testis get arrested in the normal path of descent, right? In ectopic testis, they deviate from the normal path. The name itself is suggesting, right? Undescended testis, most common site is the inguinal canal, right? Ectopic testis में most common site is superficial inguinal pouch or Dennis Brown pouch. These are all MCQ points. Now, what will be the investigation of choice? In undescended testis, remember the investigation of choice will always be diagnostic laparoscopy, because you have to do diagnostic laparoscopy and search where in the intra-abdominal part or wherever the testis is present or lodged or not, right? treatment, what will you do? You will just do orchidopexy, but it is done in 6 months to 1 year. And orchidopexy is a slow procedure. You just bring down the testis into the scrotal sac via successive surgeries. Now, coming to testicular torsion, this is also an important question. Most common cause is bell clapper deformity, testicular torsion. Apart from that, inversion of testis. What is testicular torsion? That is inversion of testis due to increased abdominal pressure. It can also be there, right? Now, how will you? They will give you history for testicular torsion. They will tell you there is the high-lying testis, right, and thick spermatic cord, and also the cremasteric reflex will be absent. In the question, they will give you these important points, right? What? The testis will be high-lying, spermatic cord will become thick, and absence of cremasteric reflex will be there. Now, regarding tests, French test will, if French test is negative, that means whenever you elevate the testis, the pain does not get relieved, right? Okay. Whenever you elevate the testis, the pain does not get relieved. Now, French test is that is negative. French test positive means in epididymoorchitis, what will you see? Hello. Now we can see here, see, French test positive will be there in epididymoorchitis. If there is epididymoorchitis, whenever you elevate the testis or you support the testis, there will be pain relief. That is French test positive. Now, you have the deeming sign. Deeming sign, what is happening? Affected testis becomes high lying. You already know, if they have two testes, one testis has undergone testicular torsion due to pulling of the or twisting of the spermatic cord, the affected testis will become high lying. So this is one of the classical signs for testicular torsion, and this sign is called as deeming sign. Now, angel sign, what is happening? Contralateral testis is low lying. Simple. Deeming sign, due to testicular torsion, the affected testis moves up. That is deeming sign. The contralateral testis lying down, or the unaffected testis lying down, that is called as angel sign, right? Investigation of choice for testicular torsion will be Doppler, right? Emergency or treatment, you already know that in testicular torsion, it is an emergency situation. You immediately have to do emergency orchidopexy if it is not ischemic. If it is ischemic, if the testis has become ischemic, the blood supply to it has been compromised, right, and the testis has started getting damaged, then what will you do? You will do orchidotomy. Now, coming to varicocele, this is also important question they have asked you, right? In what is happening in the varicocele? There is abnormal dilatation of the pampiniform plexus of the veins. You can see here the testis has the pampiniform plexus of the veins, and if there is abnormal dilatation of the pampiniform plexus of the veins, that is called as varicocele. So what are you going to do here? So, and most common site for varicocele is left testis. Always remember, this is an asked question. Most commonly affected site, that is left testis, there is the high risk of varicocele. Now, in question, they will give you key points for varicocele. They are dragging sensation in the scrotum or bag of worm sensation. Two important keywords. If they give you these two keywords, bag of worm sensation or dragging sensation in the testis, scrotum, then you have to go for varicocele. What is the gold standard here? The gold standard is duplex imaging or venography, right? Now, come here. Coming to another topic, that is hydrocele. So in hydrocele, what you are going to see, there is collection of fluid between the testis and tunica vaginalis, right? Most common, it is more commonly congenital hydrocele. Why does it happen? It happens due to persistence of processus vaginalis. This is also an asked question. Due to persistence of processus vaginalis, the hydrocele is the most common cause of a congenital hydrocele, right? Now, in acquired cause of hydrocele, most common is filariasis in endemic regions. Wherever there is filariasis is endemic, you will see it is the most common cause, acquired cause of hydrocele. Now, tests, regarding test, they will give you characteristics. You can look at the image. Trans illumination test is positive in hydrocele, very important one, right? Important question point. Then 3 testis appearance will be there. Now, so investigation, what you do, you do the scrotal FNSC. It is now contraindicated, it is not done. Always remember, in hydrocele you don't have to do scrotal FNSC, it is contraindicated. Now for treatment, what will you do? You will do Jabulais operation, okay? And what do you do in this? You do eversion, EVERSIO, eversion of the sac. Why do you do eversion of the sac? To prevent fluid accumulation between what? Between the testis and the tunica vaginalis. I hope you can understand now, right? Now coming to the Fournier's gangrene, this is also a very important asked question. December, I think in December 2022 FMG exams they asked you. Now in Fournier's gangrene, important, they have asked you what are the important points. We will tell you. It is necrotizing fasciitis of the scrotal lesion, right? And important point is it is idiopathic, right? Polymicrobial infections are there. Both aerobes and anaerobes are infecting the scrotal sac. Now important point is that testis and cord structures are spared. Very important point. Always remember, in Fournier's gangrene, scrotum and other parts will be affected, but the testis and the spermatic cords and other structures, important structures, they will be spared. And if they are spared, what will happen? Now they are safe, so you do not have to remember that. Understood? Now testis is exposed and testis is covered by coconut dressing. This is the management. Important point again. And what other things you will give? You will give IV fluids, you will give IV antibiotics and surgical debridement of the wound. Done. Now coming here to the congenital abdominal wall disorders. So just have a look. Congenital abdominal wall, 2 important congenital abdominal wall disorders they have discussed. One is the omphalocele, one is the gastroschisis. They have asked many times, right? In omphalocele, how will you correlate? Just look at the image. They will tell you intestines are exposed outside the abdominal cavity, but everything is covered by membrane of peritoneum and amnion. Done. Now it is generally, omphalocele is associated with trisomy of 13, 18 and 21. And one more thing, understand, omphalocele is generally covered by the membranes, but it will have poor prognosis. Very important point, remember, omphalocele will have poor prognosis. Question point. And you can look from this image. Coming to gastroschisis, the intestines are not covered with membrane, and the prognosis, how will be the prognosis? It will always be good prognosis. Okay, fine. Coming to the disorders of the kidney. See, so what they have asked in kidney. Most common, first of all, we will coming to the renal stones. What they ask you. Now, you have the calcium oxalate stone, that is the most common stone. Now, since it is a calcium oxalate, calcium is a metal, you already know, and metals there will reflect the X-rays, right? So the stone calcium oxalate or any metal containing stone, it will be radio opaque, right? You need not remember, they have asked you which stones are radio opaque, which stones are radio lucent. So very common, very simply you can examine and remember very easily by the trick that whatever stones that contain metal salts, they will be radio opaque, right? Because metals reflect back the X-rays, right? So they will be radio opaque. Now there are 2 main types. One is the monohydrate calcium oxalate stones, and you can look here, and you have the dihydrate stones. So just look at the images, I will show you. Now in monohydrate stones, they have asked you how do they look. They are dumbbell shaped, right? Or mulberry stones. In dihydrate stones, you have the enveloped crystal like appearance. Have a look. You can see in this image the dumbbell shape appearance of the crystal. This is the monohydrate calcium oxalate crystals. Now you have the envelope shaped crystals. In this image you can look here, it is the dihydrate envelope crystals. Now come to the uric acid stones. What will you see? In uric acid stones, again, since uric acid is an organic acid, so you need not to remember radiolucent or radio opaque. It will always be radiolucent. Why? Because it is an organic acid, uric acid. So it will be a radiolucent stone, right? Now in uric acid stone, what will happen? The urine will become acidic in nature. Uric acid stones are generally seen in associated with gout. Treatment you already know for gout, allopurinol. Now coming here for the triple phosphate stone, struvoid stone, or also known as staghorn calculi. right? There is increased risk of UTI by Proteus bacteria in this, right? Another thing, this triple phosphate stone or struvite stone, they are radio opaque in nature, and the microscopic shape is coffin lid like, right? Why are they called staghorn calculi? Because in the renal pelvic calyceal system, these stones keep on enlarging and apply this and occupy the shape of the reno pelvic calyceal system whenever they are taken out, and they can destroy the entire renal architecture also, right? So these stones, they get too large, and also they are called as staghorn, and this is appearing like the multiple horns of a deer. Coming to cystine stones. Cystine stone, what is going to happen? Again, stone will be radio opaque. It is associated with cystine urea. Now, cystine stones are very hard stones and dense stones, so they will be radio opaque, right? Seen in cystine urea. Now, since they are hard and dense, so ESWL, right, extracorporeal shock wave lithotripsy will not be effective because the stone is very hard and dense. So what will you do? For treatment, you will give D-penicillamine for the management, and for the larger stones, you will have to do percutaneous nephrolithotomy, surgery for the large stone, right? Now, coming here to the ammonium urate crystals. So, ammonium urate crystal, what is going to happen? They are radiolucent in nature, and they are associated with laxative abuse. They will give you important line, question line. They will give you history of laxative abuse. Now, come here, one more disorder from the kidney. After the stones we have finished, they have asked you about the horseshoe kidney. So, in horseshoe kidney, what is happening? There is fusion of the lower end of the kidneys at the level of L3 vertebra, right? One more important question they had asked you, this is an important previously asked topic, that ascent of the kidneys is in the horseshoe kidney is failing due to which artery? So it is due to inferior mesenteric arteries. Once they had given you an image from the abdominal branch of abdominal aorta, they had shown you one artery, and then asked you which artery should it be. So you can, it is very simple. I have told you from the MCQ point anatomy question integration that ascent of the kidney is prevented in horseshoe kidney. Ascent of the kidney is prevented due to inferior mesenteric artery. So now in anatomy, if they give you this question, you can easily solve it. Now come here, intravenous pyelogram. What will you see? Very classical question point they have given, flower vase sign or handshake sign. You can look here in the image. From the radiology portion we have covered here, right? We have covered it, flower vase sign. And best investigation here is CECT abdomen. Now, in horseshoe kidney, they will ask you whether division of poles is advised or not. You just have to answer division of poles is not advised. Coming here for the polycystic kidney. One more topic that we are going to cover in adult, autosomal dominant polycystic kidney disease, right? It is generally autosomal dominant in adults and associated with, we are covering the patho part also. They've asked you many times. PKD1 gene and PKD2 gene present on chromosome 16 and PKD2 present on chromosome 4 in adults, and in adult it is autosomal dominant. In children it is autosomal recessive, right? And it is present on chromosome 6. Dhyan rakhna. Now in polycystic kidney disease, you can see in children it is present on chromosome 6. It is autosomal recessive, whereas polycystic kidney disease in adults is present on chromosome 16, PKD1 gene, chromosome 4 PKD2 gene, and it is autosomal dominant in adults. Now, polycystic kidney disease, since kidneys is involved, you will find flank pain, very good, flank mass, and hematuria. Most common complication will be hypertension. First line of investigation for polycystic kidney disease is ultrasonography. Now, come here. In IVP, what you will see? You will see the spider leg appearance. Investigation of choice here will be CECT abdomen. Now, treatment, what will you do? Initially, you will just do the de-loofing of the cysts and symptomatic management will be done. In later stages, if due to polycystic kidney disease, there is renal damage or chronic kidney disease, then in those cases, you will have to go for renal transplant understand, initial stages mein only you have to do de-roofing of the cysts present in the kidney and symptomatic management. Suppose if the patient comes in late stage, then this due to this polycystic kidney disease, there will be chronic renal failure or chronic kidney disease, right? And if there is chronic renal failure or chronic kidney disease, then the ultimate surgical management, what will you do, is renal transplant. Okay, now come here, look at the image here. Now one more thing they have asked you is about putty kidney. So putty kidney, where does it happen and why does it happen? It occurs due to hematogenous spread of the tuberculosis, TB, right? And we already know in TB, from the pathology part, can you recall and tell me, in TB what is happening? We are facing caseous necrosis, right? In TB you find caseous necrosis. So there will be caseous necrosis and calcification will be there. So what will be the investigation of choice? In putty kidney, the investigation of choice will be CT urography. Treatment, what you will do for treatment? You will just nothing. It is tuberculosis. So first you will start the anti-tubercular drugs therapy, right? Now again in the late stage you can do nephrectomy in kidney damage, if there is kidney damage. Now from the surgery they have asked you, trauma part, they have asked you about the urethral trauma also. In urethral trauma, you have two types of injury, anterior urethral injury and the posterior urethral injury. You already know the external part of the urethra generally starts. You have the prostatic urethra, then you have the membranous urethra, then comes the bulbar urethra, and at last comes the penile urethra. Am I correct? So the penile urethra and the bulbar urethra form the anterior urethra part of the urethra, whereas the membranous urethra and the prostatic urethra form the posterior urethra. Now, if suppose there is direct injury to the penis or the outer structures, there will be anterior urethral injury. Now, so what will happen? The presenting symptoms and features will be, there will be superficial perineal hematoma around the penis and the scrotum. Suppose if there is anterior urethral injury around the penis and the scrotum, the patient will present with superficial hematoma, first sign. And another sign will be blood at the tip of the meatus, they will write, and inability to pass urine. In questions they will give you very classical symptoms. Blood will be present at tip of the meatus and there will be inability to pass the urine, right? And there will be superficial perineal hematoma around the penis and the scrotum. Now come here to the posterior urethral injury. Posterior urethral injury, I told you the prostatic urethra and the bulbar urethra will be involved, right? Now what will happen in this case? In this case it will happen secondary to the pelvic fracture. Again the presenting features in the question will be same. First is what? Blood at the tip of the meatus and inability to pass urine. Try to understand one thing. Blood at tip of meatus and inability to pass urine is a common feature in both anterior and posterior urethral injuries. The differentiating point, what is the differentiating point? See, differentiating point is in anterior urethral injuries there will be hematoma around the penis and the scrotum, right? Now coming to the posterior urethral injury, what you will find here? In posterior urethral injury, since it is in the internal part, it is in the pelvis part, so there will be deep perineal hematoma, right? And one sign they have asked you is Vermeulen sign. And in Vermeulen sign, what is happening? Whenever you do the digital rectal examination of the patient, you will feel the prostate is floating, right? And this happens due to disruption of membranous urethra. This is Vermeulen sign positive. It is nothing but the floating prostate felt on digital rectal examination. And why is it happening? It is happening because of disruption of the membranous urethra. Now guys, come here. So what will be the investigation of choice? Investigation of choice here will be retrograde ureterography. Done guys? Now important topic that they have asked you from kidney is renal cell carcinoma. So here we will be dealing with everything with the subtypes of the renal cell carcinoma, different subtypes. So here not only the surgery part, we will try to cover the patho part also. Now see, subtype is clear cell carcinoma, another is papillary RCC, one more is chromophobe RBC, and another is Bellini duct collecting duct RCC, right? Now In clear cell RCC, what do you see? It generally affects your proximal convoluted tubule, clear cell RCC. Now, if they ask you most common subtype of RCC, it is the clear cell RCC. Yeah, Dakna, these are all MCQ points. Hide whatever I am discussing in this notes has been previously asked topic, and remember me and try to understand 30 to 34 pages notes, and we will be covering entire all the topics that have been asked in last 5 years in the surgery. Believe me, it will, and not only it will is helpful from the FMG exams point of view, but also for the NEET PG exams point of view. So it is not like it is covering only the FMG exam topics. Most of the topics nowadays are similar for the NEET PG and FMG as well. So now guys, what we are going to do is, now we will see the most common subtype of RCC we have seen. It is the clear cell carcinoma, RCC. Now, it is associated with von Hippel-Lindau syndrome, present on chromosome 3 defects. Papillary RCC. It is most commonly affects the DCT or distal convoluted tubule. Characteristic finding in pathology they have asked, that is the Samoma body microscopy. In the microscopy, you will see concentric circle-like appearance here. In the microscopy, that is a Samoma body, right? And for Samoma body, where else do you see? Do you remember the trick PSMM? Do you remember the trick PSMM, guys? Can anybody tell? For the Samoma bodies, where else do you see? You can see here papillary, all the papillary carcinoma, papillary renal cell carcinoma, papillary carcinoma thyroid. Do you remember, guys? Right? Mesothelioma, meningioma, serous cystadenoma ovary. I hope you guys now can remember. You can remember Samoma bodies. Now, again, it is generally papillary carcinoma associated with chromosome 7 defect. Chromophobe RCC. Tej Bengal, sir, can you please share PDF in break with? Yes, for sure. I will share the notes, annotated one. No need to worry, guys. Okay, so chromophobe RCC. Now, pay attention. For the collecting duct, I told you, for the PCT, we have the clear cell carcinoma, most common type of RCC. Okay? For the DCT, we have the papillary carcinoma, specific finding of Samoma bodies. Now, for the collecting duct, we have two carcinomas. One is the chromophobe RCC and another is Benelli duct RCC. Now, pay attention. Chromophobe RCC and Benelli duct RCC both are happening in the collecting duct itself. So, but important point, how to differentiate? See, for the chromophobe, try to remember by the point, there is chaka-chak prognosis or good prognosis. Chromophobe RCC has chaka-chak prognosis or good prognosis. So, best prognosis among RCCs, right? Now, Benelli duct RCC, B for Benelli, B for bad prognosis. Okay? Benelli duct has bad prognosis or worst prognosis. Both are happening in the collecting duct defect. Now, chromophobe, the name itself has chromo associated with chromosome, so it is multiple chromosome loss is one of the associations in the chromophobe RCC. Now, coming here for the renal cell carcinoma, investigation of choice, it will be CECT abdomen. It is most sensitive for diagnosing and staging of the renal cell carcinoma. Coming here to one more topic, that is the Wilms tumor or the nephroblastoma. See, Wilms tumor you have seen, it is generally malignant. Now, for the Wilms tumor, ekdam characteristic they will give you, age group is pediatric age group. Try to remember, pediatric age group if it is given, right? And age less than 5 years, nephroblastoma or Wilms tumor can be suspected. In the pathology part, they have asked you, in Wilms tumor, there will be inactivation of the WT gene, right? Or WT suppressor gene. Also WT1 and WT2. What is WT? Nothing. Wilms tumor is in short form WT, right? WT gene, WT suppressor gene gets inactivated. These are the WT1 and WT2 genes. They get inactivated and this can lead to Wilms tumor. Now, most commonly affected part of the kidney is upper pole of the kidney. Now, can you remember in horseshoe kidney, can you recall we told you that the lower poles of the kidneys are fused, right? Flower vase like appearance in the radiology it was appearing. Opposite is happening in the Wilms tumor. In Wilms tumor, what is happening? Pediatric age group history they will give you, and the most commonly affected part will be the upper pole of the kidneys. Am I correct, guys? Now, Wilms tumor is happening due to WT inactivation of the Wilms tumor suppressor gene, that is the WT1 and the WT2. Come here now. Clinical feature, what will be there? The clinical feature will be abdominal mass. And where will be the abdominal mass felt? It can be felt in the flanks as well, right? Because kidneys are present at the in the flanks. Now, abdominal mass will be there. There will be pyrexia. There will be hematuria, and hypertension will be there. Why? Because there will be increased renin secretion by the tumor. So there will be hypertension associated. Now, investigation of choice for Wilms tumor is again CECT abdomen, right? Treatment, what will you do? You will do surgery and chemotherapy. Done? Now listen. If the tumor size is big, if they give you, twist the question and give you like this, if there is a big tumor size, what will you do? First, you will do chemotherapy, size of the tumor decreases, then you will do surgery if the tumor size is big. If tumor size is small, you can just go for the surgical management directly, right? I hope I am clear, guys. Now, and in some cases in Wilms tumor, radiotherapy is done, but in some cases, not very common. So from the MCQ point of view, you just have to remember surgery and chemotherapy. For a big tumor, first, if they ask you, first you will do the chemotherapy to reduce the size, then you will go for surgical resectioning and management. Coming here to the ureterocele. In ureterocele, what is going to happen? You will see the cobra head appearance, right? And so ureterocele, what is going to happen? It is nothing but the dilatation, and it is a congenital dilatation of the cystic ducts, right? Now, congenital cystic dilatation of distal ureter, you know, from the kidneys comes the ureters, right? And they come here to the bladder. Suppose there is dilatation, congenital dilatation of the distal ureter, where as it enters the bladder. Why? How is it caused? It is caused by the obstruction of the urethral orifice, or orifice means opening, or if there is obstruction of the urethral opening, there will be dilatation, distal dilatation, right, of the ureter. Now, what will be the clinical features? Suppose if there is obstruction and dilatation, what will happen? The urine formed in the kidneys will come here, and it will pass into the bladder. It will get accumulated into the ureter. So what can happen? It can lead to urinary tract infection. So clinical feature will be recurrent UTIs, right? Apart from that, suppose if there is urine buildup for the long term, what can happen? There can be, due to urine buildup, the complication, there can be hydronephrosis, vesicoureteric reflux can be there, right? So these can also come as the symptoms, and there will be flank pain, abdominal pain. There will be voiding dysfunction seen in the children, because we have already seen ureterocele is the congenital cystic dilatation, right? So in children, it will be more commonly appearing in children or the pediatric age group. Now, what will happen? It is generally asymptomatic also sometimes, and sometimes ureterocele is an incidental finding as well. Coming here, what they have asked you very frequently with ureterocele is the common association, most common association. So it is most commonly associated with duplicated collecting system, right? Regarding the first line investigation in ureterocele, what will you do? You will do ultrasound, and best diagnostic tool will be VCUG and cystoscopy. Done. Now, for the VCUG, you already know voiding cystourethrogram is the full form, right? If you guys, some of them, if you don't know, or if you are forgetting, for them, I am giving the information because it's a revision class. So I hope that everybody has studied and you know that. Chalo. Complication, what is the complication, guys? The complication is hydronephrosis, right? I have already discussed why. Because there's blockade of the urethral orifice. There will be backflow, accumulation of the urine. It can lead to hydronephrosis. It can lead to vesicoureteric reflux and ultimately renal damage. Chalo. Come here. Now we are going to start another important topic, that is a trauma. So, will you give the PDF? Yes, of course, I will share. I'll share the PDF. No need to worry. We will for sure share. So coming to the tension pneumothorax, just see here. An open pneumothorax, Flail chest and pericardial tamponade. trauma, and from the trauma part we are going to start, and trauma part also the chest trauma, very important. So here we are going to cover not only the surgery part, emergency part, trauma part, and the medicine part. Very important from FMGE exam, right? For the NEET PG exam all as well. Very important because one of the favorite topics is trauma. Come here to the tension pneumothorax. So what is tension pneumothorax? Nothing. There is collection of air between the parietal pleura and the visceral pleura of the lungs. You already know the lung has the visceral pleura and outer side is the parietal pleura, and in between the parietal and the visceral pleura, if there is air collection, it is tension pneumothorax. Now come here. The cause for tension pneumothorax can be blunt trauma, right? So here what will be the features they will be presenting with? Dyspnea, tachypnea, and dilated neck veins and chest congestion, right? Investigation of choice, there will dyspnea. Why? Tension pneumothorax, they are compressing the lung, air is being collected between the parietal and the visceral pleura, they are compressing the lung tissue, no effective exchange of the air is taking place. So what will happen? The patient will be having dyspnea, tachypnea, rapid fast breathing, and there will dilated neck veins and chest congestion will be there, right? Investigation of choice, you already know, will be chest x-ray. Management, it is an emergency condition. Remember, pneumothorax or tension pneumothorax, especially tension pneumothorax is an emergency condition. You have to manage it immediately. So immediate management, what will you do? You will do needle thoracocentesis. In adults, what is the place? You do in the fifth intercostal space, mid axillary line. In the children, in some books or some authors, they tell you fifth intercostal space, anterior axillary line also. Don't get confused. Most commonly preferred is mid axillary line, right? Now listen to me very carefully. Yes, we will share the PDF, no need to worry guys. First listen and try to understand. We will share the annotated PDF, no need to worry. Come here and listen. Now in the child, for tension pneumothorax, where will you do? In the child you will do in the second intercostal space, you will do in the mid clavicular line, you will do the needle thoracocentesis. If they ask you definitive management for tension pneumothorax, chest tube insertion at fifth intercostal space, mid axillary line. Okay, now one more important concept from anatomy I will tell you. Okay, right? That is about the triangle of safety. They have asked you many times, integrating it with the anatomy, surgery, and all. So triangle of safety, that is nothing but you can see a triangle made by here. One of the border of the triangle is made by the pectoralis muscle, other by the latissimus dorsi, right? And the base is made by the sixth base of the fifth and the sixth ribs, right? And apex is made by the axilla. This is the triangle of safety where you insert the chest tube in the fifth intercostal space. I hope now you can remember, right? You have the pectoralis muscle, then you have the latissimus dorsi, apex you have the axilla, and base you have the ribs, right? And in this you insert the chest tube. Come here to the, we have discussed the tension pneumothorax. Coming to open pneumothorax. See, open pneumothorax is not as emergency condition as compared to tension pneumothorax, right? Again here there will be collection of air between the parietal pleura and the visceral pleura. You guys know. Now open pneumothorax cause is generally due to penetrating chest injury due to from the outside, right? And again the clinical features of tension and open pneumothorax will be the same: dyspnea, tachypnea, dilated neck veins, and the congested chest, right? Investigation of choice, again same, chest x-ray. And when is the chest x-ray done? Once you patch the wound. Now management, what do you do in management? Initially stages में in open pneumothorax, since the wound is open, then you apply in the initial stage. Try to remember, understand, they will ask you, twist the question, and they will ask you what management will you do in the initial stage, what management will you do in the late stage. So listen very carefully. In the initial stage, what you will do, you will apply the three-sided occlusive dressing, right? In the initial stage, making a one-way valve, right? And in definitive management, what will you do? Again, it is the same for both the pneumothorax. Definitive management, chest tube insertion, right? And since it is open pneumothorax, to open में, you will have to surgically repair the wound also, right? So surgical wound repair. Done? Understood, guys? Now, just a minute, guys. I will share the PDF. So I'll just give me a minute. You guys want PDF? I will share it. Don't worry. for that. Now come here to the next topic. Next topic what we have is Flail chest, right? In Flail chest we have seen more than 3 ribs are fractured at 2 different sites, right? Now in Flail chest one more thing you will see is there will be history, cause will be the blunt trauma to the chest, right? And classical feature in Flail chest will be the question identifying point they will give you in question. In Flail chest more than 3 ribs are fractured at more than one side, first thing. Second, they will give you the classical sign is of paradoxical breathing, right? And painful shallow breathing. This paradoxical breathing is a key point for identifying the question of Flail chest. Now there will be painful shallow breathing and respiratory failure will be there. Again, investigation of choice is same, chest x-ray. Management, here you will just give oxygen analgesia through the thoracic epidural catheter you provide. Coming here to another topic, that is the pericardial tamponade. Very important, very important. In the medicine also many times they have asked you, and also they have asked you with associated with some triad called as Beck's triad. They have asked you a lot of times. So pericardial, you already know pericardial. Pericardial means there will be collection. Collection of what? Collection of fluid or blood in the pericardium, that is between the parietal and visceral pericardium. There will be collection of fluid or blood, right? Now why it will happen? It will happen due to blunt trauma to the thorax. It can happen to the due to penetrating chest injury as well. Important point, Beck's triad, always they will give you in history a patient comes where there will be hypotension. Why hypotension? Simply just try to understand, there is the heart and there is the pericardium. Around the pericardium the fluid or the blood has accumulated. Now the heart has no space to expand or to contract. The pump is not acting. Now if the pump is not acting, what will happen? What was the heart doing? Heart was pushing the blood into the aortic system, pumping via the left ventricles. It was pumping blood right into the aorta, and via the right atrium, heart was taking blood from the superior and the inferior vena cava. Right now, just look like this. Here you have the heart. In the superior and inferior vena cava are draining blood into the right atrium, and from the left ventricle, into the aorta. Suppose heart is not able to pump, so there will be loss of less blood in the aorta. Less blood in the aorta means hypotension, heart unable to pump. Now heart is also unable to bring blood from the superior and inferior vena cava into the right atrium. So what will happen? The veins will distend, right? So what will happen? The neck veins will be extended and distended, and there will be raised JVP, jugular venous pressure will be raised in case of cardiac tamponade. Now if the pericardium is covered with fluid, whenever you will auscultate, you will find muffled heart sound. So I hope you can now very easily remember conceptually the Beck's triad. The reasons for the triad, there will be muffled heart sound, right? There will be hypotension and there will be raised JVP. These are the classical triad of the cardiac tamponade. Now come here guys. In immediate management, what will you do? You will do needle pericardiocentesis. Done. Come here to the skull, trauma of the skull. You guys need the notes, I'll tell you, and we will just share the notes. No need to worry guys. I just wanted to share you the annotated notes, but is it okay now or? Is it okay guys? Chalo, let us start now. Anterior cranial fossa, trauma to the skull. You will find here the anterior cranial fossa, the middle cranial fossa fracture, and the posterior cranial fossa fractures. Very important asked topics. You can here look here, images also we have provided. No need to worry. So come here. Anterior cranial fossa fractures. In anterior cranial fossa fracture, what will be there? There will be fracture of the, first of all, cribriform plate, MCQ point. Second, what sign? If there is fracture of the cribriform plate, there will be raccoon's eye sign or panda eye sign, right? And along with that, since cribriform plate is fractured, there is risk of CSF rhinorrhea, right? CSF plain watery fluid will be coming from the nose. That is CSF rhinorrhea. In the question they will give you. Now, Investigation, what do you do? It is the NCCT head or non-contrast CT head will be done. Coming to the middle cranial fossa fracture. In middle cranial fossa fracture, there will be fracture of the petrous part of the temporal bone. You already know this is the temple, right? Temple, and we have the temporal bone. Temporal bone has two parts. In the ENT, you have already studied, and in the anatomy also you have studied. It has a squamous part as well as the petrous part. So, whenever there is fracture of the petrous part of the temporal bone, there is middle cranial fossa fracture. Now, what are the signs will you see? You will see battle sign, right? And what is battle sign? Around the mastoid, there will be ecchymosis and bruise, present of bruising, right? And the hematoma you can see. Now, in middle cranial fossa fracture, I told you, since temple bone is here with the squamous and the petrous part, so there is risk of CSF otorrhea. Can't say, they will tell you that from the ear there is discharge of plain watery fluid. So there will be CSF otorrhea involved. Now, cranial nerves, which nerves will be damaged? You already know cranial nerve 7 and 8. Why? Because from the internal acoustic meatus of the skull comes two nerves, that is the seventh and the interfacial nerve and the vestibulocochlear nerve. Vestibulocochlear nerve supplies the inner ear, right? Responsible for hearing sensation. Can you remember? And the facial nerve comes out, and here it supplies gives the different branches. And not only that, facial nerve also supplies the external auditory canal, sensory supply it gives there. I hope you guys can recall from the anatomy or the ENT part. ENT, you might have studied about the nerve supply of the pinna. For sure, we will share the notes. Don't worry. Now, come here to the posterior cranial fossa fracture. In posterior cranial fossa fracture, there is tumor, there is trauma to the occipit region. See, occipit, this is the back region, this is the occipital region. And there is trauma to the occipital region, and contusion will be there. And in the posterior cranial fossa fracture, there will be damage to the jugular foramen or injury to the jugular foramen. If jugular foramen is injured, you know, when I will be teaching anatomy, I will be telling you how to remember the outlets of different foramens. So from the jugular foramen, you know what will be coming out. You will have 9th and 10th and 11th cranial nerves, right? And if there will the 9th, 10th and 11th cranial nerves are injured or involved, then it is also associated with a syndrome called as Wernicke syndrome. Investigation of choice, you know, NCCT. So we will just recall once more, and you can see here the raccoon's eye sign. This is anterior cranial fossa fracture. CSF rhinorrhea will be there. Battle sign, ecchymosis and bruise at the back of the ear, at the mastoid, near the mastoid, right? It is the middle cranial fossa fracture, fracture of the petrous part of temporal bone, and also will present with CSF otorrhea. Done, discussed. Very commonly asked. Posterior cranial fossa fracture, I have told you. Now coming to abdominal trauma. Very high yield MCQ point we will be discussing here. Abdominal trauma. Most commonly abdominally trauma में injured organ is spleen. Overall in all cases of trauma, most commonly injured organ is spleen. Now coming to blunt trauma, they will ask you blunt trauma, which is the most commonly injured organ? Spleen. Now suppose if you forget in the examination, you go and you forget, sir, how will I remember? I will give you a very simple trick. Suppose you entered into a fight with anyone and somebody punched you on the abdomen. Listen to me very carefully. Most of the people, 70, 80, 90% of the people are right-handed, right? They are right-handed. So if somebody punches you from his right hand and you are standing on the opposite side, he will most probably damage the left side of yours, right? He will punch you on the left side of your abdomen. So, and on the left side, you know the spleen is present. So from this trick, you can remember in the exam, even if you forget. So most common blunt trauma site is the organ to be, abdominal organ to be damaged in blunt trauma abdomen is spleen. I hope I am clear, guys. Now, one more thing. In penetrating injury, suppose you already know liver is a large organ, right? Present here on the right side, covering the anterior aspect. So whenever there will be penetrating injury, your first organ or most common organ to be damaged will be liver, right? Second most common, if they ask you, is generally small intestine. If liver is not in the option, then you can tick for small intestine. Now, car seat belt injury is the injury to the mesentery. You will have to remember mesentery will be injured. You know the car seat belt, it is present like this and runs like this. So most commonly it is covering the abdominal part, and it will lead to most commonly trauma to the mesentery. Trauma by gunshot Again, the most commonly involved part will be small intestine. These are all asked MCQs. They have asked you in surgery, trauma part, and they are not only that, they have also asked you in forensic part, if you guys can remember. Right? In forensic also they have asked you. If patient is, and now coming to investigation, surgery part, they ask you, if the patient is stable, what investigations will you perform? So the first investigation that you will perform is E-fast scan. Earlier they used to give you fast, now you have to tick for E-fast. Suppose both are given in option, then E-fast will be your preferred answer. If they have not given E-fast, then you can tick fast. Now come here guys, investigation of choice for immediate investigation, if they ask you, it will always be E-fast and fast. Investigation of choice, if they ask you in trauma, it should be CECT abdomen. Now suppose if the patient is stable and unstable, if patient is unstable, okay, then first investigation and investigation of choice will always be in this case E-fast. Are you understanding? If in question they give you a patient with abdominal trauma came to you and the patient is unstable, hemodynamically unstable, what will be your first investigation and investigation of choice? In both the cases, if patient is hemodynamically unstable, your answer will always be E-fast. Done. Because you have less time, so you just have to locate the site of trauma and start managing the patient, right? Suppose now come here to radiology. From the radiology part, they have asked you very important questions. Just look about the seashore sign and also about the barcode sign. Come here, look at the seashore sign, right? Seashore sign, generally it is the normal present on the left side. This image is the seashore sign. You will see normal line like appearance and then sandy grain like appearance, right? This is the normal seashore sign. It is a normal sign present in every individual, but in healthy individual or every individual, right? Barcode sign, where does it appear? All everywhere, line, where, or also called as stratosphere sign. Where does it appear? It appears wherever there is case of pneumothorax, most commonly, right? When the pleuras, lung pleuras, they are not intact. In case of pneumothorax, you can see the barcode sign, right? These are the appearance in E-fast scan when you see you are doing, and the appearance in the USG or ultrasound. E-fast scan when you are doing, you can just look for the pneumothorax, barcode sign, or the stratosphere sign. I hope you can recollect radiology, surgery, every part we have covered from the trauma, abdominal. Now one more part, that is the retroperitoneal trauma. They have different zones. One question they have asked you from the retroperitoneal trauma. So zone 1, zone 2 and zone 3. Zone 1, very simple, you do not need to remember, just see. Zone 1, in the midline, centrally it is present. So centrally, what are the structures present behind the abdomen? It is the vertebral bones, right? Vertebra, and along with vertebra there will be, it is the bony part, the soft part will be aorta and the inferior vena cava. Am I correct? Now just see, in the, you can see from this image, in the central zone you have the aorta and the inferior vena cava centrally present in the retroperitoneal part, right? Now in the periphery part or in the zone 2 you have the kidneys. Am I correct guys? You can see in the zone 2, you can, in the flanks you can see the kidneys laterally present. Now in the zone 3, you know, you have the organs that are present below, that is organs present in the pelvic cavity, pelvic retroperitoneal cavity, right? In the zone 3 you have organs that are present in the pelvis retroperitoneally. Now come here, coming to the GCS, Glasgow Coma Scale, very important. So questions what they've asked you, I will tell you. Mild GCS is 13 to 15, moderate is 9 to 8, severe is 8 or less than 8. Now why I have written in this notes need for intubation in bracket in severe 8 or less than 8. Suppose they give you a question, we will be discussing the GCS. Before discussing GCS, we will discuss very important point. What I will tell you, if in the question they give you a patient comes to the hospital, you calculate his GCS and his GCS comes out to be 8 and the patient is conscious, what will be your next best step? Can you guys answer? I'm waiting for your answer. Please, some people try and attempt to answer. Please answer, some guys. Some people are discussing about the blast. Yes, we will discuss that also. Okay, fine. We'll discuss, but first answer that. Simple, will you do for all the subjects? Yes, yes, we will be doing for all the subjects. We will doing for all the subjects, 19 subjects. We are trying to do subject wise. Yes, we are covering all the topics, everything for surgery we will cover. Nothing will be left. Whatever they have asked in the last 5 years, all the topics will be covered. Subject wise, we will doing covering all important and 19 subjects. No need to worry. Even if you do this session in the last moment, that is more than enough. And we will be giving you the notes also. Don't worry. Just tell me answer. If in the question they give you, patient comes to you with GCS 8 and he is conscious, what will be your next best step? Can somebody answer? Yes, Dr. Kunal, it should be intubation. Very good. Why? Even if they give you GCS is 8 and the patient is conscious, always remember, if GCS is 8 or less than 8, you will, the next best step will always be intubation, because there is risk of patient becoming unstable, hemodynamically unstable, or going unconscious, right? So always prefer the next best step. Even if the patient, in the history they will give you, he is conscious, just intubate the patient. Now come here. If the GCS is 3, then what will be your response? Either the patient is dead or the patient is in deep coma. Now come here. For GCS, remember the trick EVM. E is eye opening, V is verbal response, and M is motor response, right? Eye opening, you have EVM. 444 you have. Just see, eye opening spontaneously. If the patient is opening his eye spontaneously, you just name the patient, and you just look at the patient, he has opened his eye spontaneously, you give 4 points, right? If he is closing his eyes and you have to name him, Mr. Ram Prakash, please open your eyes, then you open his eyes. To speech, then it is 3 points, right? If even after speech is not opening and you have to inflict pain to the patient, you pinch the patient, you put pain to the patient, and then he opens the eye, right? Like this, giving an irritated look, then GCS 2. Even if you pinch, inflict pain to the patient, but still he is not opening, there is no response, 1 point will be given. Eye is done. Coming to the verbal response, right? If the patient comes to your emergency, he is oriented to time, place, person, he is talking, conscious, and talking matlab sanely, not insanely, he is talking conscious and sanely, that means GCS. In the verbal response, you will give 5 points. Now suppose the patient is conscious, talking, but he is confused. Where am I? Why am I here? Why? How did I come here? He appears to be confused. Then the score you will give him 4. Now suppose the patient is there coming to the emergency and he is using inappropriate words, Ram, Sita, Gita, classroom, school, anything, inappropriate words, anything, random. You cannot confirm, you cannot form a meaning from that. He is not able to form anything meaningful sentence, just using words, inappropriate words, 3 points. Now if the patient is unable to say any word, he is just making sounds, moans and groans, he is just moaning in pain and groaning in pain, that is just kara raha hai, you can understand, right? Then 2 points. No response, 1 point. Come here. For the motor aspect, if the patient comes and you tell him, Ram Prakash, please lift your left leg, and he lifts his left leg. Ram Prakash, please move your right hand, he moves his right hand. He is obeying the command, right? 6 point. Now if he is not obeying the command, then what will you do? Again, if you inflict pain to the patient, then he moves to the localized pain. If you inflict the pain and he is moving to localized pain, 5 point. Now if you give the pain and if just flexes withdrawal to the pain, only flexion withdrawal to the pain is there, 4 point you will give, right? Now coming to abnormal flexion, if you inflict pain to the patient and there is only abnormal flexion, that is 3 points, right? If you inflict pain to the patient is unconscious and only abnormal extension is there, that is 2 points. No response, 1 point. Now wait a minute. Here with abnormal flexion and extension, I would like to tell you one more thing, right? What is it? 2 important points. In place of abnormal flexion or extension, they can give you in question decerebrate and decorticate response as well. They can write you decerebrate, and for abnormal flexion they can write you decorticate also. So no need to get confused and worried. Okay, I will give you the notes, guys. We'll share that on the Telegram channel and the link. No need to worry. Chalo, aa jao. You have here the decerebrate and decorticate rigidity. What is happening in decerebrate decorticate? See, if the upper limbs are in flexion, right, and lower limbs are in extension, this is called as decorticate. If the upper and the lower limbs both are extended, it is called as decerebrate, right? Now, moving from GCS, we have discussed. Come here to the types of hematomas they have asked you. EDH, SDH, and diffuse axonal injury. One more is SAH, subarachnoid hemorrhage. We will discuss everything. No need to worry. Coming here to the EDH. In EDH, what is going to happen? In EDH, extradural hematoma, the name itself is suggesting. There will be collection of blood between the dura and the skull. It is extradural hematoma. Now, generally, it is caused due to temporal blunt injury. History, they will ask you which artery or vessel will be damaged. It will be middle meningeal artery. I will give you a trick for this. Generally, I don't prefer tricks, but I will give you a trick, very beautiful trick, and you will be able to remember forever. Lucy की मम्मा ने idli banaya. Now wait, why I told you? Very important, because some students cannot remember, some students forget. For those, I have made this trick. Lucy की मम्मा ने idli banaya. See, Lucy is lucid interval. In the question, if they give you that the patient comes with history of lucid interval head trauma, then you will suspect for EDH, extradural hematoma. MMA, mamma is damage to the middle meningeal artery. Idli, why idli? Because the hemorrhage shape, you will see it appears to be biconvex or idli in shape, right? Done. Coming to SDH, subdural hematoma. Subdural hematoma, the hematoma is sickle in shape, right? Now, generally, it is happening due to the damage to the, in the question they will give you, if they do not give you the image, radiological image, they will give you history, or they will ask you which vessel is damaged. Then you will answer damage to the cortical bridging veins, right? Also, most commonly, boxer's hemorrhage. History, what they will give you, pupils dilated and not responsive to light. Now, management in every EDH and SDH, both, it will be burr hole craniotomy. Investigation of choice will be NC-CT head, non-contrast CT head, in both the cases. Now, coming to subarachnoid hemorrhage, if they give you history of subarachnoid hemorrhage, what they will tell you, in the classical history and question, they give you worst headache of life, patient comes and complains with worst headache of life, or they will give you, there is history of thunderclap headache. Okay guys, there is history of thunderclap headache, that is subarachnoid hemorrhage. Now, one very classical case, they will give you that a patient of head trauma comes to you and you do the NC-CT head and the findings is completely normal, right? Finding is completely normal. In NC-CT head, you are unable to find any pathological finding. Tell me what is the diagnosis. Now, if they ask you like this, so what will be your answer here? Then what will be the next best step? Your next best step will be go for MRI. Why? It can be a case of diffuse axonal injury. Dr. Puneet, sometimes SDH में भी ये क्या lucid interval मिल जाता है सर? हाँ, sometimes in SDH also lucid interval can be ये fine, but SDH में नहीं, SCH में, but don't go for that. Classical history MCQ based exam है. Go with the only MCQ classical findings. In your exam, they give you clear cut history. Whenever they tell you lucid interval history, right? Middle meningeal artery damage, or they give you biconvex shape hematoma, aankh moon ke, you have to go for extradural hematoma. Don't get confused in the last moment. Sometimes whatever you have told is correct. Sometimes you can see, but no need to get into more into that, right? Now, one more thing. Here, there will be damage to the cortical bridging veins, and yes, only go for the classical hit MCQ points. Because you are giving an MCQ based exam, so rare findings or rare things will not be asked. Classical common things they will enter, and then you have to locate. Along with that, they will give you other findings. The beauty of clinical question is that only one keyword they will not give you. They will give more than 2 keywords. So you can correlate if there is damage to middle meningeal artery, if there is biconvex shape hematoma and history of lucid interval present, you can easily tell it is EDH, right? I hope you understand. Okay. Okay, fine. I will make it, okay, fine. Now, come here. In diffuse axonal injury, let me pull the mic. Is the audio clear now? Come here. In diffuse axonal injury, you will see the NCCT head will be normal, but there will be damage. Why? There will be damage to the white matter and gray matter. Why? Because there will be disruption between the complete white and the gray matter because of the shearing force injury between the gray and the white matter, right? Coma will be present here. Now, NCCT will be normal, but in MRI, you will get the findings, right? You will get white, hemorrhagic like spots present in the entire field, and the prognosis is worst in case of diffuse axonal injury. Coming here to the important topic, that is the burns. In burns, they have asked you a lot of questions. Every year you get questions from the burn. Now, come here. So we are almost about to finish. People are losing patience or not. Yes, chalo, let us start. Come here to the burns. Burns, most common type of burn they have asked you. Very important question. That most common type of burn, day-to-day case mein, what do you see? You see the scald burn. Done. Most common burn cases in hospital, what do you see? You see the flame burns. Toxins, suppose if there is flame burn, so, or if there is burn, so what most common toxicity, what will you see? It will be the carbon monoxide poisoning. It can obviously, it can be understood, right? Now, forensic, answer me one question. What is the color is seen in the carbon monoxide poisoning? Can anybody tell me, in carbon monoxide poisoning, what is the color seen? Brick red color or cherry red color? Somebody please answer. Forensic CO poisoning. Nobody is attempting. Why? So many people are watching online live. Very good, Dr. Puneet. Cherry discoloration. Very good, Dr. Ansh. Yes, very good. So forensic. See, this is the beauty when you interact in the do interactive live sessions. You interact with the questions, with the topics, and integrate with different subjects. Very good, everyone. Dr. Basila, Dr. Madhu God, Dr. Kunal. Nice, Dr. Rohit, Dr. Irresistible, and Rishi. Everyone, thank you and very good. Chalo, now come here. For hypovolemia, what is happening? First, you see 24 to 36 hours is crucial. In burn, they've asked you what is the most common risk. So there is risk of hypovolemic shock in the burn because the tissue is burned, the vessels are exposed. There is a risk of fluid loss and there is a risk of hypovolemic shock. Now, sepsis may occur through the burned skin. Most common organism that is involved in burn is the responsible for sepsis is Pseudomonas. These are all high-yield MCQ points. Now, coming here to the assessment of severity. You have to assess for the severity of the burns. So, first of all, they will give you in history, if a patient comes to you, he had suffered burn in a closed space or closed area, first finding. Or they can ask you that a patient comes to you and he has symptoms of signing of hair, burning and presence of soot particles in the nasal, in the nostrils as well as in the around the mouth. There's presence of soot particles. They are all characteristic findings indicative of inhalational airway injury or inhalational burn. Understood? Fine. I hope you can understand the key points that they will give you in question. Presence of soot particles around the mouth, around the nostrils. There will be history of signing of hairs or burning of hairs, right? Characteristic finding indicating of inhalational airway injury or inhalational burn. This is important for surgery burn questions as well as this is also important for forensic part because they will give you the dead body comes in for the post-mortem. There is presence of soot particles everywhere and there is into the airway, into the mouth, there is presence of soot particles and there is signing of hairs. There are characteristic findings of antemortem burning. Antemortem burning, if there is presence of soot particles and everything inside the airway, right? And post-mortem burning, there will not be the presence of soot particles inside the airway. I hope you can understand, right? Differentiating points. We have discussed on the forensic also. Come back here. Come back to the surgery part. If there is inhalational airway injury, the burnt nasal hair and signing of hair, we have discussed this. So what will you do if a patient with inhalational airway injury comes to you? First line of management, early airway protection. Early airway protection, what you have to do? suspect airway injury and intubate the patient. Next best management is suspect airway injury and intubate the patient. Now, if the patient comes late, what is the complication? The complication is there is laryngeal edema. If there is laryngeal edema, what will you do? Now you will do immediate management, immediate next best management. These are all MCQ and question points. They ask you like this, what is the next best stage? That is why I am completing a scenario and telling you and discussing with you. So please listen to me very carefully. Listen, if the patient arrives late with laryngeal edema already set in, then you cannot intubate. Then your next best step will be needle cricothyroidotomy. ठीक? You will just do the needle cricothyroidotomy, and once you stabilize the patient, then you will go for tracheostomy, definitive management. Understood, guys? Now, we already have studied about the Wallace rule of 9. It is now used for the adults and children's. Now, just see for the Wallace rule of 9. Adults के case में what do you see? Nothing. The head here 9%, thorax 9%, abdomen anteriorly again 9%, right? Legs you can see here 9%. The perineum and the palms, they are 1% each. ठीक है? Then again the thorax at the back, the abdomen at the back 9%, the legs at the back again 9%. You can see here. Children again you can see here, right? In children the head area is bigger. Only exception what you have to remember, one more chart they have asked is London-Browder chart, but this London-Browder chart is not very commonly used. Why not very commonly used? Because in emergency situation you have less time. Suppose if they give you in question a burn patient came to you and he has in the thorax he has a little bit area burned. So how will you calculate the burnt area? Entire area is not burned, small burn is there. How will you calculate the area? Do nothing. Take a piece of paper along the palm of the patient, palm of not the doctor, palm of the patient. Draw the area of the palm because area of the palm corresponds to 1%, right? And then keep that piece of paper. Suppose 2 pieces of paper cover the wound, then the total burnt area will be 2%. Understood? And what should be the size of the paper? It should be the size of the palm of the patient. Why? Because palm of the patient has 1% of the total body surface area. Understood? ये तो सब बना लोगे. Everybody will be able to solve this. If they give you कि thorax and abdomen anteriorly they are burnt, then you can easily tell 18%. If they tell you leg is anteriorly burned and posteriorly burned, then you can easily tell 18%. But suppose in case if they give you small area is burnt, right? Small area such as only this much area is burned. How will you calculate the burnt area? Similarly, just take the area of the palm, cut a paper of the size of the palm of the patient, put the paper on the area, and number of papers required to cover the wound will be the total area, because one palm area will be equal to 1%. Suppose 2 papers required, then 2%. 1 paper required, then 1%. I hope I am clear. This is the most complicated thing that they can ask you regarding the surface area of the burn. Now, just have a look here. What you are going to see. Come here for the degree of the burn. You will see here, you have the first degree burn, second degree burn, third degree and fourth degree they have asked you. So, generally in first degree burn, always remember it is the epidermis is involved. If only epidermis is involved, there will be only pain, redness and swelling, no blister. Remember, first degree mein only epidermis involved and no blister formation. Pain, redness, swelling, nothing else. Superficial, partial and superficial and deep partial. Here comes the second degree and third degree. In superficial, partial and deep partial, that means second and third degree. In second degree, first degree only epidermis, second degree mein dermis is involved. And what kind of dermis? Papillary dermis. Remember MCQ point they've asked you. Papillary dermis is involved. Up to papillary dermis it is second degree burn or superficial partial burn, right? From the if papillary dermis is involved, and whenever the dermis is involved, there will be blister, right? Skin and severe swelling. Done. Blisters will be formed from the second degree burn. Third degree burn, what will happen? Again, the dermis is here also involved, but the part of the dermis is reticular dermis. Again, MCQ point they have asked you. Reticular dermis is involved. Now, what will the characteristic? Here again, white, leathery and relatively painless. Why? Because from the third degree burn, the nerve endings start to also get damaged. So it will be relatively less painless. Fourth degree burn or full burn, what will happen? It will reach to the deeper tissues and there will be formation of iskar. Remember iskar formation. Now, one question that I have is, if there is iskar formation, what will you do? Will you remove the iskar or will you leave the iskar as it is in case of fourth degree burn? Important question, answer me. Can anybody tell me for the iskar formation? Nahi. No, Dr. Kulbhushan. If scar actually acts as a protective dressing, so you don't remove the scar. Somebody, yes, very good, Dr. Irresistible and Dr. Kunal. You just leave the scar as it is. You do not remove the scar. Scar tissue is left as it is. Now, coming here to the colloids, crystalloids, right? The fluid of choice given is colloids and crystalloids you give, right? Now, apart from that, what will you do? You will calculate how much amount of fluid has to be given. That is done by the Parkland's formula. And it is 4 into body weight into total surface area burnt, right? Now, first 50% of the fluid calculated from Parkland formula is given in first 8 hours, right? In next 50%, remaining 50% is given in next 16 hours. Can you remember total fluid amount of fluid that is calculated that has to be given out of the total amount of fluid? Suppose the amount of fluid comes out to be 5 liter or suppose 2 liters, right? So 50% of this 2 liter, that means 1 liter will be given in first 8 hours, right? Remaining 50%, another 1 liter will be given in another 16 hours. Okay guys, now come to another topic, that is the shock. Shock may you have the hypovolemic and hemorrhagic shock, right? So types of hemorrhage, what are the hemorrhage? You have the primary hemorrhage, secondary and reactionary hemorrhage. They have asked you. In primary hemorrhage, it is generally done, it occurs generally during surgical process itself, surgery itself. Reactionary hemorrhage occurring within 24 hours of surgery, right? And the most common cause for reactionary hemorrhage is slipping of ligature, suture knots, right? Secondary hemorrhage occurs generally after 7 to 14 days of the surgery and it is generally due to infection or SSI, surgical site infection. Now, come here. Come here to the classification of hypovolemic shock. This is also important topic. They have asked you. Idhar aa jao. Class 1, class 2, class 3 and class 4. We have multiple classes of hemorrhages, right? Now, blood loss is less than 750 ml, ठीक है? 15% is class 1. 750 से 1.5 लीटर का if there is blood loss, it is 15% to 30%. Total body fluid is 5 liter, total blood volume 5 liter. If there is class 1, less than 15% of blood loss is there. Class 2, there is 750 to 1500 ml or 15 to 30% of blood loss is there. Class 3, there is 30% to 40% of blood loss. Class 4, there is 40%. Very easy to remember. 1, 15%. 2, 30. Less than 30, 15 to 30. Class 3, 30 to 40. And class 4, 40% onwards. Done. Now, very simply, listen to me very carefully. Heart rate, what is going to happen? In class 1, what will you see? You will see heart rate is less than 100. In class 2, what will happen? Heart rate will be more than 100. Why? Because class 1, very less amount of fluid is lost. Since less amount of fluid is lost, what will happen? The heart will try to contract, relax, pump, and it will try to compensate. What it will try to compensate? Compensate for the loss of the fluid volume, and it will easily be able to compensate. So the heart rate will be less than 100. Now coming to class 2. In class 2 hemorrhage, what is going to happen? If the hemorrhage is more than 15 to 30%, heart here will again try to pump, increase the heart rate and try to compensate for the lost amount of fluid, and hence the heart rate will be more than 100. So if the heart will, in both these cases, generally what will happen? Heart will try to compensate, and in class 1 and class 2, due to compensation, heart rate will increase slightly and BP will become normal. Focus on the points. How to remember? BP will become normal in class 1 and class 2. Just see, Because the heart has increased the pumping rate and compensated for the blood pressure. Come here for class 3. In class 3 hemorrhage, what is going to happen? Heart rate will increase more than 120. Even after heart increasing, because 30 to 40% of the, almost 1/3 of the body fluid has been lost. If 1/3 of body fluid has been lost, heart will be unable to compensate. It will beat very fast. It will become more than 120. And even if it beats fast, it will be unable to compensate for the fall in BP. So blood pressure will decrease, right? Class 4, we already know almost half of the blood or more than 40% of the blood is lost. So what will happen here? The blood pressure will obviously decrease. Coming here to the pulse pressure. Pulse pressure, we told you class 1, very less amount of blood has been lost. Heart will pump and it will increase a little, the heart rate by little bit amount, and it will compensate. So pulse pressure will be normal here. In class 2, what will happen? The pulse pressure will decrease. Class 3, very much decrease, and in class 4, it will decrease. Coming to respiratory rate, again, if the heart is beating fast, you will have to breathe. Why? Because the cardiac tissue requires oxygen, right? So you will increase the respiratory rate to 14 to 20, 20 to 30%, and 35% se zyada, right? And 30 to 40. Now coming to the urine output. For urine output, what you will see? More than 30 ml. Normal. Urine output, you don't need to remember everything. Just remember for the class 4 it is important and class 1 it is important. Rest, it is normal. In class 4 it is negligible. Urine output is more than 30. Now come here. CNS, they don't ask you, not very much important. Lethargic, confused, they have mentioned. We have, but not very important. In the short revision, only we will go for the blood loss, the heart rate, the BP, the pulse pressure, and the respiratory rate. Come here to the shock summary table. One more thing. They have asked you about the hypovolemic, cardiogenic, and disruptive and obstructive shock. Most important among them is hypovolemic, cardiogenic, and distributive. So come here. First of all, in hypovolemic shock, what is going to happen? See, why is happening for hypovolemic shock? It is happening due to loss of blood and the body fluid. Now, the key features will be, you will see the peripheries. If there is loss of blood and fluid, what will happen? The body's priority is to supply blood to the core or the vital organs, that is the brain, the kidneys, the livers, and the heart, right? So in the peripheries, the blood supply will be reduced. So in hypovolemic shock, you will have cold, clammy hands, right? Hypotension will be there. Systemic vascular resistance. What will happen to the systemic vascular resistance? It will be increased. Why? Because it has to compensate for the reduced volume. Since there is reduced volume, in order to compensate for the reduced volume, systemic vascular resistance will increase. Management for hypovolemic shock will be, you will give fluid, you will do blood transfusion if needed. Coming to the cardiogenic shock, name itself is suggesting. In cardiogenic shock, what is going to happen? Yes, in cardiogenic shock, what is going to happen? In cardiogenic shock, there is failure of the pump or the heart. Now, if there is pump failure, example MI, what is going to happen? There will be pulmonary edema, right? Because we have already discussed and told you, we have the cardiac tissue heart, inferior vena cava and the superior vena cava are bringing blood into the right atrium, and from the pulmonary arteries, the right ventricle is pumping blood to the lungs, right? And here in the left atrium, you will see the blood is coming from the pulmonary vein, and in the left ventricle, the blood is going into the aorta. Now listen to me very carefully. If there is pump failure, blood will not be coming from the lungs or the pulmonary circuit to the heart. So blood will be accumulating here in the pulmonary tissue. So there will be pulmonary congestion, right? Now, central venous pressure will be high. Now, what will happen to the systemic vascular resistance? Again, it will be increased. Why? Because there will be compensatory vasoconstriction. Management, again, cardiogenic pump failure is there. So you will to stimulate the pump, you will give inotropes, you will do revascularization, and diuretics you will give to relieve from the pulmonary edema and the congestion. Distributive shock, what is going to happen? See, only shock. Acha, vasodilation will be there in the distributive shock, right? What you will see here? Some more things, guys. Warm extremities and the bounding pulse will be there, right? Systemic vascular resistance, what you will see? Decreased profound vasodilation and this will cause low systemic vascular resistance. Now, management, fluids you will give, vasopressors you will give, and treat the underlying cause. Done. Now, important point, question, important point, what they have asked, I will tell you. Listen to me very carefully. Question, important point, suno. Question, important point क्या क्या है? Listen to me very carefully. I'm going to tell you. Distributive shock, only shock where systemic vascular resistance is going to decrease. बाकी सब में systemic vascular resistance will increase, but in distributive shock, systemic vascular resistance will decrease. First. Second thing, systemic vascular resistance. What will happen in most of the shocks? You will find the hands in hypovolemic, the hand will be cold and clammy. Only shock where the peripheries will have warm extremities and bounding pulse is the distributive shock. It is also example of septic shock. So septic shock may be very simple trick to remember is in septic shock, what do you see? You have fever, infection, sepsis is there, right? Sepsis is there, infection in the blood is there. So in infection, what will happen? There will be fever. So peripheries will be warm. From this trick you can remember, right? In distributive shock, you have the warm extremities. We have discussed the important question points. Now coming to the obstructive. Obstructive is not very much important, but you can see there is physical obstruction. We have already discussed such as tamponade, cardiac tamponade or anything, right? There will be absent breath sounds. We have discussed this, right? JVP will be raised and increased against SVR, systemic vascular resistance will be increased because of reflux vasoconstriction due to reduced cardiac output. Now, management, nothing. Relieve obstruction, that is needle decompression. We have discussed this already. So no need to pay very much stress. Only important 2 points I have told you. Distributive shock or septic shock, you will find the peripheries warm and the pulse will be bounding. Second important MCQ point is the systemic vascular resistance will be decreased. In rest, all of the shocks, systemic vascular resistance is increased. Coming to the suture material, have a look here. Classification of suture materials, you can see here. The document provides a classification. Suture material, you can see here. Now, absorbable sutures you have, non-absorbable sutures you have. Among the absorbable, again, you have to go for the synthetic and the natural ones. Non-absorbable, you have to go for the synthetic and natural ones. Again, you can look for the images also. What we have put here, polyglycolic acid is there, right? Dexon is there, polygalactin is there. Natural, you have the plain gut or also called as cat gut, right? Chromic gut or also called as chromic cat gut. ठीक है. Synthetic में देखो polypropylene, nylon, tetrafluorourethane, ethylene and all. Natural में silk and cotton linen are there. You just have to look. आ जाओ. Now coming to the vascular grading, right? Coming here to the Boyd's grading, you have here the grade 1, grade 2, grade 3 and grade 4. Grade 1 is calf pain, right? On walking further improves. Grade 1 Boyd's grading. Grade 2 is we have the calf pain on walking doesn't improve further. Grade 3 cannot continue walking, rest is required there. And grade 4 pain in the foot at rest and rest pain is there, right? Grade 1 there will be relief whenever the patient walks. Grade 2 calf pain and walking will not improve further even on walking. Grade 3 what will happen? Rest is required and the patient is unable to continue walking. He cannot continue and walk further. Grade 4 pain is there in the foot, rest pain is there. Now coming to the topic of thromboangiitis obliterans. There in thromboangiitis obliterans what is happening? The small to medium vessels are affected and here you will see smoking is a major risk factor. Arteries, veins and nerve, all these things are involved, right? But important point, the lymphatics will always be spared in thromboangiitis obliterans. Arteries, veins and nerves will be involved. The lymphatics will be spared. Now, it is generally associated with Raynaud's phenomena, right? Thromboangiitis obliterans. And what is Raynaud's phenomena? Nothing. In cold, what is happening? They will give you 3 characteristic features. The hand will turn white when it is exposed to the cold. Again, when there is lack of oxygen, it will turn blue. And later on, when the blood flow is restored, it will turn red. Again, why? Because of vasoconstriction. Once the blood flow is decreased, another time due to decreased blood flow, deoxygenated blood will accumulate in the fingers and the tissues. It will turn blue. Again, when the blood flow is increased or restored, the fingers and the hand will turn red. Now, come here. We have discussed this Raynaud's phenomena, color change, again white, blue, and red. Management, what will you do? You already know for the management, you will give calcium channel blockers and the nitrates. You know nitrates, they are the smooth muscle relaxants. They will dilate the blood vessels, right? CCBs, calcium channel blocker. Again, they will also do the same thing. Now, coming here to the DVT. Deep vein thrombosis, most common site again, we have the calf vein. Most common cause of prolonged immobilization whenever the patient is bedridden for a longer period of time, post-operative cases, right? Then there is risk of deep vein thrombosis. Now, coming here to the important triad from the general pathology, you can correlate. You have the Varicose triad. In the Robbins, you will see they are given you a triangle and they show hypercoagulation, endothelial injury, and hemostasis or stasis, right? They all together make the Varicose triad, and if in the Varicose triad there is high risk of thrombus formation increases, right? Now, Homan's sign in DVT will be positive. Moses sign they will give you positive. Perthes test is also done. Now, investigation of choice, important question point for DVT they have given you is duplex imaging. Now come here, come and look at the varicose vein. In varicose vein, you can see from the image you have the large twisted veins, dilated veins, superficial veins, right? Other symptoms, itching around the veins, burning sensation is there, muscle cramps are there, right? Discoloration is there around the varicose vein, right? And throbbing sensation is there. In varicose vein, the most common is the lower limb involved. Due to saphenofemoral incompetence, you will see complications. What you will see in venous ulcer, the most common you can see site, and the complications is venous ulcer, and the most common site for venous ulcer is middle malleolus. Near the middle malleolus, you can see here, near the grade 2, near the middle malleolus, on this side you can have formation of ulcers. Now, SEEP classification is there: C0, C1, C2, C5, C6. Not very frequently asked, but yes, you can go through it. For FMG, not very much important. Coming here to the Marjolin ulcer, so we can skip this if you guys wish, but as it is very easy, there is no visible or palpable signs of venous disease. In C1, there is telangiectasia or reticular veins. Reticular, you already know, reticular means network of veins. In C2, there is varicose vein distinguished from the reticular vein by a diameter of 3 mm or more. In C3, you will find the edema. In C4, they will have subcutaneous tissue secondary to changes in the skin, and subcutaneous tissue will be there, and this will be secondary to the CVD, right? And it is further divided to C4A and C4B. In C4A, what is happening? There will be pigmentation and eczema, and C4B, there will be lipodermatosclerosis or atrophia blancae, right? In C5, what is happening? The venous ulcer will be healed. In C6, there will be active venous ulcer. Now coming here to the Marjolin ulcer. Now, if there is an ulcer and that is long-standing venous ulcer, may further complicate into Marjolin ulcer. Very commonly complicates into SCC, squamous cell carcinoma. Very commonly asked MCQ point. Now, investigation of choice again will be duplex imaging. Now, how will you identify the Marjolin ulcer? You can see here. Fungating soft tissue mass. Now it will increase in the size, foul smell, in addition to X-rays, right? And they will also show chronic osteomyelitis. Coming here to the next, some scores, very important scores we will discuss. See, they have asked you about questions about the Q-SOFA scoring. So Q-SOFA scoring, you can see here, the parameter is altered mental status, right? First of all, they have asked you what are the parameters included in the Q-SOFA scoring. This is an asked important point. So just have focused on that. So altered mental status is there. If GCS is less than 15, then 1 point is given. Systolic blood pressure is there, less than 100 mmHg BP, then score again 1 point is given. Respiratory rate more than 22, again 1 point is given, the Q-SOFA score. Coming to the Southampton grading, this Southampton grading and asepsis score, both are given, discussed, and asked. There is high probability that these two scores can be asked. Coming to the Southampton grading. Okay, Southampton grading, what will you find? In Southampton grading, you will find grade description is there. Grade 0, normal healing with no inflammation or discharge is there, right? And so, how to remember Southampton grading? Very easily, very skillfully, I will teach you. Just focus on this. In grade 0, what will happen? There is no healing. The wound is there, no healing, no inflammation, no discharge. Grade 0. In grade 1, what will be happening? Normal healing will be there and mild bruising and erythema. Nothing else. Mild bruising, erythema, grade 1. Grade 2, erythema will be there, and apart from erythema, there will be serous discharge, thin watery serous discharge. No pus, nothing like that, right? Grade 3, clear purulent discharge will be there, right? Grade 4, deep or severe wound infection involving tissues, organs will be there, right? Now, coming here to the asepsis, deep or severe wound infection involving tissues and organs will be there. Now, come here. Interpretation of Q-SOFA score we have done. Coming to the asepsis score. Asepsis score, this is also given in very low. You can see these are asepsis and Southampton. Both are done for wound assessment, right? And SSI, surgical site infection, wound assessment. There also you do the SSI scoring you do for the asepsis and Southampton. Both the scores are important. Now coming to the asepsis score. See, whenever a score component, whenever additional treatment is required, you in this condition you give 10 points. Okay. Whenever there is serous discharge, thin water discharge, you give 5 points. Wherever there is erythema, again 5 points. If pus is coming out means infection has already taken place. If infection has taken place, then you give 10 points. Due to pus collection, there will be separation of the deeper tissues. So again, it will be giving 10 points. Isolation of bacteria from the culture medium you give 10 points, right? Stay prolonged over more than 14 days, you give 5 points. Okay, guys. So these are the scoring, the asepsis scoring you have done. Southampton and Q-SOFA you have done, right? Now coming to the interpretation of Q-SOFA score, we have already discussed. If they are in Q-SOFA score, I told you the three they have asked you is 3 important parameters present in Q-SOFA scoring. First is altered mental status, second is systolic blood pressure, third is respiratory rate, right? For each 1 point is given. Suppose if the Q-SOFA total score is between 0 to 1, then there is low risk of outcome, low risk of poor outcome. Poor outcome will not be there sepsis mein in this case, right? If more than 2 is there, the Q-SOFA scoring, then there is high risk of poor outcome, right? So interpretation of Q-SOFA score, you already know there will increase risk of mortality and ICU admission likelihood. Now guys, we will be discussing some other important topics. If you guys need a break, or we can just continue with that, because 1 to 1.5 hours we need, and we will just finishing. So let us start with the thyroid part, right? Thyroid part is also important. Or start from this page. Coming to the oral part, cleft lip and cleft palate, you can see most common congenital anomaly of the orofacial structures, cleft lip and cleft palate, right? In cleft lip, what is happening? This is due to the failure of fusion of the medial nasal processes and the maxillary processes, right? In cleft palate, there is failure of fusion of 2 palatine processes, right? Now, the drugs responsible or associated with the cleft lip and cleft palate are phenytoin, diazepam, and steroids, right? Okay, some are telling break. Now, diagnosed after 18 weeks of pregnancy on USG, right? Generally, cleft lip and cleft palate. Problems faced is breathing, airway, and speech and dentition. You already know, because the left lip and the palate, if they are malformed, there is no fusion, then what can happen? There can be malformation. There can be problem in the breathing. There can be problem in the airway maintenance. Also, the dentition will be improper. Also, when you want to speak, or the phonation will also be impaired. Right now, coming here to the treatment, you do it as a surgical correction. Nothing else. For surgical correction, the operation preferred is Millard's operation, done at, if the operation done between 3 to 5 months, it is done for cleft lip, 6 months soft palate, and 12 months hard palate repair. Done. Millard's operation, you can see 3 to 5 months cleft lip, 6 months, then you have the soft palate, and more than 12 months hard palate. Coming to cystic hygroma. Cystic hygroma done in the posterior triangle of the neck. They will give you the picture like this, big due to sequestration of the jugular lymphatic sac will be there, right? Trans illumination test will be positive, right? And management, what will you do? Two management. First option, if complete excision is there, that will be preferred option. If it is not given, then you will go for the aspiration as the option. Now, nausea, vomiting at now come here. Cystic hygroma, you will see. Now, in the operation or due to cystic hygroma, there is risk of damage to a nerve. What is the nerve involved that can be damaged? Is the spinal accessory nerve. Done, guys. Coming to the ranula. Ranula kya hai? Nothing. It is, you can look on the image. It is a mucus extravasation cyst. Now, again, since it is a test, trans-illumination test will be positive. Just a minute, hold. Whatever we have studied abhi tak till now, we saw trans-illumination test was positive at 3 places. One is the cystic hygroma, another is ranula, and third was hydrocele. If you can remember, in hydrocele also trans-illumination test was positive in these 3 conditions. So all now remember. Now, coming here to the ranula again. Mucus extravasation cyst, trans-illumination test is positive. Now, treatment, what will you do? You will do excision of the cyst required, right? Or marsupilization. Excision of the cyst required or marsupilization also, right? Now, gland damage, since you can look here, it is at the submandibular region, lower part of the mandible, there will be submandibular gland will be damaged. Nerve damage will be, again will be the lingual nerve that will be damaged. Coming here to the thyroid part. In thyroid, you have the thyroglossal cyst. You can look here. So, why the thyroglossal cyst happens? This happens due to persistence or secretions. This happens why? Because there is persistence of what? Thyroid tract, right? Now, secretions and accumulate and they are present now. What will happen? Subhyoid, the location, most common location is subhyoid. Now, thyroglossal cyst, always it will occur in the midline. And in the history, in the question, they will give you, whenever the patient moves the tongue or protrudes the tongue, there will be movement, right? Whenever the patient protrudes the tongue, there will be movement of the thyroglossal cyst. Operation performed is cyst trunk operation. Cyst, thyroglossal cyst trunk operation is performed. What do? You do excision of the thyroid tract and excision of the cyst. Now, diffuse goiter. Where do you see diffuse goiter? Wherever there will be diffuse iodine deficiency, or in case of pregnancy, in case of puberty, Graves and Hashimoto, you will see diffuse goiter route. Now, multinodular goiter, where will you see? It is seen in long-standing case of iodine deficiency. Coming to Hashimoto, decuvarian and Riddle's thyroiditis. 3 we have. So see here, in the Hashimoto generally, we will be discussing 3 important thyroid disorders now here. Hashimoto, decuvarian and Riddle's. In Hashimoto, it is a chronic disorder, right? It is an autoimmune disorder, right? And what will be happen? It will be associated with anti-TPO antibody. Also associated with HLA-B8, DR3 and DR5. Done. There will be swelling in the midline and it will be painless. The surface will be nodular. Done. Initially in Hashimoto, we told you anti-TPO antibody is being formed. So initial stages, what will happen? There will be hyperthyroid, and in the later stages, it will turn to hypothyroid. Diagnosis, thyroid function test you have to do. You have to do USG, you have to do FNSC and anti-TPO. I told you associated with anti-TPO antibody. So anti-TPO antibody titer you have to do, right? Since in the later stages, lifelong hypothyroid stage will be there. So for the treatment, the patient will have to take lifelong thyroxine. Coming to the decuvarian, again, it is a subacute condition. It happens due to post upper respiratory tract infection, or also happens sometimes due to after post viral infections or post upper respiratory tract infection. It happens, right? Associated with B35. Now there will be midline neck fullness. It will be painful and associated with fever symptoms, right? And what will be happening with the thyroid levels? It will be hyperthyroid in the initially in the decuvarian, and then euthyroid. That means it is self-limiting. It is happening due to viral infection or upper respiratory tract infection. It is generally self-limiting in nature. You do not need to give any treatment. Investigation is always TFT and USG. Riddle's mein what is going to happen? Riddle's mein chronic thyroid is there, right? Idiopathic, massive midline swelling will be there. Severe pressure will be there symptoms. dyspnea, dysphagia, and hoarseness of voice will be there. Simple. Severe pressure symptoms, if the thyroid is increased too much, it will compress the trachea, esophagus, and the underlying structures. So there will be dyspnea, there will be dysphagia, and there will be hoarseness of the voice, right? Again, initial and later stages, always there will be hypothyroid in riddles. Treatment is again, if there is constant hypothyroid state, lifelong thyroxine you will have to give. Test में thyroid function test, USG and FNSC you do. Coming for the thyroid cancers. Now, if there is pressure symptoms involved, then you do hysterectomy. Thyroid cancers, you have three: papillary, follicular, and medullary carcinoma, right? Papillary carcinoma, it arises from the follicles. Again, PTSM. Yeah, PSMM. Again, I told you Samoma bodies. You can remember, right? We have discussed already initially when we were discussing the RCC. Now, papillary carcinoma arises from the follicles associated with BRAF gene, and it appears in the question. They will give you history of solitary thyroid nodule like presentation and no swelling will be there, right? Investigation, thyroid function test, FNSC and USG. Follicular carcinoma, you see the follicles will be involved here. The genes involved will be P10 and BAX. Goiter like pulsatile swelling will be there and nodular surface will be there, right? The investigation will be thyroid function test, USG, FNSC cannot differentiate. Coming here to the medullary carcinoma, the C cells will be involved, RET genes will be present. In C cells, you will see okay, now calcitonin, serotonin will also be increased, you will see with the C cells associated with it, right? And there will be secretory diarrhea. Bus. Now you will see TFT, FNSC and USG. Come here in the investigation we have discussed. Now we will coming to the HPE. Now, what will be the findings for the papillary carcinoma? In the microscopic finding, patho part we are going to discuss, they will discuss. In the orphan any eye nuclei is seen, you know, in the papillary carcinoma we have seen. Samoma bodies, we already told you the trick, PSMM. You will see in all the papillary carcinomas. Now, dystrophic calcification will be there. Coming here to the follicular carcinoma, what will you see? Abundant oxyphilic cells will be there. In medullary carcinoma, you have seen amyloid will be present in the stroma. You have seen ACAL-like, you can remember from the patho, ACAL-like deposit seen. Now, coming to retrosternal goiter, just evaluate this image. What you will see, there will be enlargement of the thyroid gland. Then thyroid gland enlarges behind the sternum, and there's dyspnea, dysphagia, engorge, and if there is enlargement of the thyroid gland, it is compressing the trachea, the esophagus, and the vessels involved here. So what will going to happen? There will be neck veins engorged, and facial veins engorged, right? And due to compression, there will also be stridor. They will show you, I have asked you about the Pemberton's test. What is it? Nothing. There will be flushing of the face on raising both the hands above the head. If they ask you, you can now do it. Treatment, nothing. Removal via neck incision, cervical incision you give and you remove. Right? Coming here, they have asked you the thyroid examination. Different tests they have given you. Pizillo's methods, Lahey's and Creeley's method. Three important questions and images they have given. First, if they give you a woman keeping her hand behind the head and asked to push against the occiput, that is Pizillo's method. In Lahey's method, you will see examiner stands facing the patient and he is pushing the gland on one side to palpate the margins. You can see here the second image is of Lahey's method. Creeley's method, thumb is kept on the gland and patient is asked to swallow and you check for the nodules. Now look, in some in examination they may give you two thumbs are, this is also the test. In some photos or images they will give you one thumb is kept, right? That is also correct. Don't get confused. If the thumb is kept and you are examining and asking the patient to swallow and examining for the nodules, then it is Creeley's method only. Coming to the GIT constrictions, some books and people tell there are 4 constrictions, some say 3 constrictions. Not a big deal, nothing controversial. I will tell you how. Just have a look here. You have the cricopharyngeus at the level of the C6, narrow. Then you have at the level of the arc of aorta, major constriction. It is at the level of 25 centimeter from the central incisor. Central incisor you are measuring at the 25 centimeter. Then you have at the level of the left bronchus. Now see, this is at the 28 centimeter distance from the central incisor. And this is the proper reason. The reason is that the arc of aorta and left bronchus, they are very near to each other. So some books consider 4 constrictions and some consider 3 constrictions only. They consider both these constrictions as one, right? So nothing debatable. Cricopharynx, C6, 15 centimeter. For these two, generally some books and some teachers they tell, like aortic arc and left membracus, they are only one constriction. And at the level of esophageal hiatus, that is at the level of T10, you see as the diaphragmatic opening for the esophagus. Now, the important levels are important. Vertebral level, C6 is very important. Then aortic arc, T4 is important, and T10 level is important for the esophageal hiatus. Coming here, you will see here we have discussed. Coming for the Zenker's diverticulum. Zenker's diverticulum, very easy, nothing. It is just a diverticulum. Acha, is it a true diverticulum or a false? Can anybody tell me? So it is a false diverticulum. Why? Only 2 layers are involved. The mucosa and the submucosa protrudes out, not the all 3 layers. Now, what you will see in the Zenker's diverticulum, you know, we have the Killian's dehiscence, the weakest area. And Killian's dehiscence is made a triangular area where it is made. How is it made? You have the at the base you have the cricopharyngeus, and then the triangular part you have the thyropharyngeus muscles. Thyropharyngeus muscles making the arms, and the base of the triangle is made by the cricopharyngeus. They make a weak muscular area, and from this area there is protrusion of the diverticulum called as the Zenker's diverticulum. Now, important points regarding Zenker's diverticulum, I'll tell you. It comes in the midline, but the tip of the sac is diverted towards the left lateral side. Remember, Zenker's diverticulum comes out from the midline, but the tip of the sac is diverted towards the left lateral side. Always remember, important point they have asked you. Now, what are the clinical features? Clinical features will be regurgitation, halitosis, and dysphagia. Done. Signs, what are the signs you will see? They have given you voice sign positive. Investigation of choice again is barium swallow. Now, if the diverticulum less than 2 centimeter, you do cricopharyngeal myotomy, right? 2 to 4 centimeter, you just go for diverticulopexy. More than 4 centimeter, Dolman's operation you go for, right? Now, achalasia, coming to achalasia cardia. So, what is achalasia cardia? The lower esophageal sphincter here fails to relax completely, right? And there will be symptoms. What are the symptoms? There will be dysphagia to the liquids initially, then to the solids. Understand? Now, just a minute, I'll take a pause here. Suppose in question, if they give you dysphagia to solids first or dysphagia to liquids first, how will you differentiate, how will you determine, and how will you know? Very easy. Suppose this is the esophagus is a tube-like structure, right? In achalasia cardia, you know there is failure of relaxation of the lower esophageal sphincter, right? Now, this lower esophageal sphincter, if it is not relaxing, suppose you put a liquid diet in the pipe. Esophagus is a pipe, muscular pipe. You put it, it will be unable to exert the pressure. So the esophagus will not open. But if you put any solid food substance, it will exert pressure and it will open the lower esophageal sphincter and the food will pass through it, right? So first of all, you will find that is why in achalasia cardia, you find dysphagia to the solids first, liquids first, but not to the solids. Now come here. In carcinoma esophagus, suppose what is happening, you have a tube, there is a malignant growth or a cancer growth here, right? Obstructing the tube. So suppose if you take any liquid diet, so liquid is shapeless. Even if there is partial obstruction due to the tumor growth in the esophageal pipe, the liquid will pass through it, right? But due to the tumor growth in the esophageal lumen or pipe, if you take any food or solid food substance, it may get trapped because the solid is a shaped heavy thing, right? It may get trapped because of the mass of the lumen. So dysphagia to solid first will appear in carcinoma esophagus. I hope now you can differentiate from the question, and even if you forget, you can recollect by this simple concept that when there will be dysphagia to the solids and when there will be dysphagia to the liquids, right? Now come here guys, another what we are going to do is causes. We have the idiopathic, most common cause, right? Achalasia cardia. Again, another cause kya hai? There is failure of the migration of the neural crest cells. Given, they give you the clinical features. What will happen? The clinical features which you will see is dysphagia to the liquids first will be there, then to the solids. Regurgitation will not be there. Retrosternal pain and cramps will be there, and weight loss will be there. Causes: idiopathic, most common cause, esophageal cancer, stomach cancer will be there, right? Chagas disease association causative agent can be there, and amyloidosis can be there. Now, first investigation, what will you see? First investigation, barium swallow or bird beak sign you will do, right? You can see here the bird beak sign present in the image we have shown you, and the pencil tip rat tail sign when esophageal carcinoma is present. First esophageal manometry we do, right? In the medical management, what do? You give the calcium channel blockers. Surgical management or the treatment of choice, what you are doing? You simply know. Also, in medical management, you also give botulinum toxin, right? Or Botox. Why? Because there is failure of the relaxation of the esophageal sphincters. What you have to do? If you give botulinum toxin, it will paralyze the muscle. You already know. What does botulinum toxin do? It prevents the release of acetylcholine vesicles into the synaptic cleft, right? So acetylcholine will not be released. Muscles will fail to contract. They will get paralyzed and they will relax. Botulinum toxin is given. Calcium channel blockers, again it will relax, right? Now, surgical management, what you are going to do? You are going to do Heller's myotomy, most important. Then you can do per oral endoscopic myotomy also, POEM. Coming to diffuse esophageal spasm, also called as nutmeg esophagus, you can see here the corkscrew appearance. We have discussed here in barium swallow, right? In Skarsky ring, you have seen here, right? Barrett esophagus, we have already seen. Barrett esophagus, what is happening? Barrett esophagus is generally associated with gastric esophageal reflux disease. Suppose a person is having gastric reflux or the gastric reflux or the acid reflux. Somebody is suffering from that. The lower esophageal sphincter is involved. What will happen? We know in the esophagus, the lining is non-keratinized, stratified squamous epithelium lining is there, right? In the stomach or the intestinal part, you have the columnar epithelium, glandular epithelial lining, right? Now, so what is going to happen? In this case, suppose if acid production is there and the lower esophageal sphincter does not close properly, there will be acid reflux. If acid reflux will be there, it will continuously keep on damaging the lower epithelium of the lower 1/3 of the esophagus, right? So what will happen? The epithelial cells will transform from the epithelial type to the glandular type to prevent themselves from the acid damage. That is what is called as Barrett's esophagus. That is why it is called as metaplasia, intestinal metaplasia. Now, hallmark, how will you identify? The hallmark will be presence of tall, columnar, glandular cells having goblet cells in between, right? Treatment, what will you do? In treatment, just you will do the endoscopy and you will do the endoscopic resectioning, and most common treatment, first line treatment is always lifestyle modification and PPIs. You will give. After that, then you will do endoscopic resectioning, surgical management, followed by radio frequency ablation. Coming to GERD. GERD we have already discussed, gastroesophageal reflux in very much detail. Nothing, it is the primary cause that will ultimately lead to Barrett esophagus. There will be reflux, right? Lower esophageal sphincter fails to relax. I have already discussed this. Gold standard investigation for GERD is 24 hours pH manometry. Asked question. Many times they have asked you. Now, management is lifestyle modification. We have told you. Surgery for GERD is floppy Nissen's fundoplication. You do nothing. You have the stomach. You take the stomach tissue. You wrap it around the esophagus and Nissen fundoplication. Image also they have asked you for Nissen fundoplication a lot many times. Coming here to the hiatal hernia, sliding hernia, rolling hernia. What we can see here, right? So in sliding hernia, you can see what we have. Esophagus. Rolling hernia, we have seen the two differences they have asked. Sliding hernia is more common. Rolling hernia is less common, right? In the sliding hernia, you can see in the gastroesophageal junction, thorax more commonly. Rolling hernia, abdomen, right? Reflux is present in the sliding hernia, whereas it is absent in the rolling hernia, right? Up now, clinical features, again, both the hernias, it is same. It is the chest pain and the dyspnea. Now, first investigation of choice, both of them, it is the same. That is the chest x-ray you will do. Investigation of choice will always be CT scan with oral contrast, right? Treatment, fundoplication only in both the cases. Bore-Heavy syndrome. Bore-Heavy syndrome, what is Bore-Heavy syndrome? It is the complete tear, through and through tear. That means involving all the layers. Can you tell me the layers of the esophagus? In entire GI tract, you have 4 layers. That is the mucosa, submucosa, muscularis, right, and the serosa. But in esophagus, serosa is absent. Instead of serosa, you have the adventitia layer, right, guys? Now, you see here, in Bore-Heavy syndrome, what is happening? There is through and through tear of all the layers. So, what is going to happen? Due to breakage of the layers, there will be, what you will see? There will be leakage of the contents. Where? So, the clinical features, what you will see? Very easily, if there is breakage in the through and through of the pipe or the esophagus, there you will see the features of subcutaneous emphysema. Air from the GI tract will come and dislodge, and it will accumulate subcutaneously. So subcutaneous emphysema, most common features. Whenever you will be pressing or auscultating, you will find, listen, they will give you in the history of brutes. You will listen to the brutes. On auscultation, subcutaneous emphysema will be there, right? Now, also they will give you macular stride. What is macular stride? Complete tear is there. There will be vomiting, there will be chest pain and subcutaneous emphysema. They form the macular stride, important for the Bore-Heavy syndrome. Now, they have asked you about the most common site of the tear, that is the posterolateral wall of lower esophagus. Now, first investigation, what do you do is pneumomediastinum chest x-ray you will do, and you will find pneumomediastinum. I have already told you subcutaneous emphysema is there. So in the mediastinum, air will be there. So pneumomediastinum finding will be there. Chest x-ray mein. Investigation of choice, CT scan you will be doing with iohexol contrast. Treatment, what you will do? Nothing. You will do thoracotomy and mediastinal lavage, because the gastric contents, the acidic contents they may leak into the mediastinum. So to prevent any further sepsis or any infection, you will have to do the mediastinal lavage. You will have to wash it, right? Now, 3 important tears, Bore-Heavy syndrome, malarious tear and esophageal varices they have asked. So we will be discussing them. Bore-Heavy syndrome, I already told you, they will transmural, through and through tear, right? It is happening due to binge drinking. Macular stride we have discussed. There will be chest pain, nausea, vomiting, right? And subcutaneous emphysema you will be seeing there. Now, in malarious tear, what are you seeing? Again, history of binge drinking will be present, but in malarious tear, only mucosal level tear will be present. So only history of hematemesis, nothing else. No subcutaneous emphysema. When you auscultate, you will not find any brutes, right? Now, esophageal varices, what will you find? It is a chronic liver disease, right? And there will be mucosal and submucosal tear again, and associated with case of chronic liver disease, liver cirrhosis. You will, when you will open the book of Pathology, Robbins, and also in Davidson, you can find they have very clearly they mention about the esophageal varices, and when they tell you that generally esophageal varices first incidence only is fatal. In most of the cases, almost more than 90% of the cases, 95% of the cases, first incidence of esophageal variceal bleeding is fatal. Right? Now, hematemesis will be there. Differences we have discussed and seen according to the history. Coming to the CHPS, pediatric surgery part, congenital hypertrophic pyloric stenosis part. So, here in the CHPS part, we will be discussing again. The name itself is suggesting congenital hypertrophic pyloric stenosis. There is hypertrophy of the pyloric sphincter, right? So, hypertrophy of the circular muscle fibers in the pylorus present during, it is always associated with pediatric age group. So, congenital, the name itself is suggesting. So, you will have 2 to 6 weeks of presentation. Some people write 3 to 5 weeks of presentation as well. Both are correct. No need to worry. Just look for the history, 2 to 6 weeks or 3 to 5 week presentation, right? And just go for what? Pediatric age group, newborn, history rahega. Vomiting will be projectile and non-bilious in nature. Why non-bilious? You see here, just look at the biliary tract. You have the liver, comes from there, you have the left and the right hepatic ducts. Coming here, you have the gallbladder, and from the gallbladder comes the, tell me, cystic duct. They join the common hepatic duct and form the common bile duct. Now, this common bile duct comes to the pancreas and joins the pancreatic duct, and in the duodenum opens at the point of sphincter of Oddi. Right? Now, just look at the tree. In the duodenum, the pancreas, the bile tree, the biliary ducts, they are opening, joining the pancreatic duct, and they are opening via sphincter of Oddi in the duodenum. and here the pylori, so here it is the opening of sphincter of Oddi, and there is hypertrophy of the pyloric sphincter. If there is hypertrophy, that means the duodenal contents or the bile cannot reach into the stomach. Yes, so the vomiting will always be projectile, forceful, and non-bilious in case of congenital hypertrophic pyloric stenosis. I hope you understand the concept. Now, come here. Suppose if there is vomiting, continuous vomiting, there is vomit, the patient is vomiting the acid. The acid present in the stomach is hydrochloric acid, you know, HCl. If you are continuously vomiting the acid, you are losing acid. So if you are losing acid from the body, what it will lead to? It will lead to metabolic alkalosis. Apart from that, the acid was hydrochloric acid, so chloride is also lost. So that will be hypochloremic, hypokalemic, metabolic alkalosis. Am I correct, guys? Just have a look and tell. Now come here. So in CHPS, what will you find? You will find olive shaped lump. You will feel on palpation, you will find olive shaped lump. Now investigation of choice will be USG abdomen. The pylorus will be thick, and treatment, what you are going to do? You are going to do Ramsted myotomy or pyloromyotomy, right? Single bubble sign will be present. You can see here. In coming to duodenal atresia, so in duodenal atresia, what is happening? There is absence of some part of the duodenum. Simple image you look, just you will have the dual bubble sign, right, and double bubble sign. And since there is duodenal atresia, there will be, the vomiting will be bilious. I have already told you about the biliary tract. I told you why the sphincter of Oddi, everything, the bile and the other contents are coming into the duodenum. So if there is duodenal atresia, suppose below or lower part, right, so the vomiting will always contain bile. Jejunal atresia, there will be triple bubble sign. They have asked you radiology mein, right? Coming to peptic ulcers, so peptic ulcer, the most common site is duodenum overall. Most common site in stomach is angularis incisura, all MCQ points. Cause is H. pylori infection. Other causes are NSAID abuse, Zollinger-Ellison syndrome. Stress is one of the common aggravators of peptic ulcers. Now, so guys, now we'll discuss about the gastric ulcers and the duodenal ulcer. Come here, guys. So in gastric and duodenal ulcers, we have seen important features we will be discussing. See, remember one law, acid irritates the ulcer. I'll tell you why. Because in question they have asked you many times very important things, that weight loss, they will give you history of weight loss, weight gain, and they will expect from you to answer which kind of ulcer it is. Very simple. Remember one law, that is acid irritates the ulcer. Now, if there is ulcer in the stomach, gastric ulcer is there, acid is being secreted, right? Whenever the patient eats anything, what will happen? Acid will be released. Now this released acid will irritate the ulcer, right? When the ulcer is irritated, what will happen? The patient will feel pain. So if the patient, they give you in history, patient feels pain immediately after having food, that means it is indicative of stomach ulcer or gastric ulcer. Why? Acid is released. This acid is damaging, right, the ulcer, irritating the ulcer. The patient feels pain. Now, due to the after immediately eating food, patient feels pain, so patient will avoid having food. And if patient will avoid having food, what will happen? There will be, tell me simply, weight loss. In the case of gastric ulcer, you will find history of weight loss, pain immediately after taking food. Done. Important points discussed. Now, in stomach, gastric ulcer, there is risk of formation of adenocarcinoma. Done. Coming here to the duodenal ulcer. Again, I told you acid irritates the ulcer. I am going to tell you very important point from the physio and histology point of view also. Just focus. In duodenum, you have the submucosal gland, that is the Brunner's gland. These Brunner's gland secrete the bicarbonate, right? Brunner's gland releases bicarbonate. What is going to happen now? This Brunner's gland releases bicarbonate. Bicarbonate is a base, right? It neutralizes the acidic chyme coming from the stomach into the duodenum. Now, you see, if you have the duodenal ulcer, what is going to happen? The base or bicarbonate is being released in the duodenum. Now, this released base or bicarbonate neutralizes the acidic chyme coming from the stomach. So if patient eats food, a patient with duodenal ulcer eats food, what will happen? The base will neutralize the acidic chyme coming here. The patient will feel relaxed. So patient wants to eat more and more food, because immediately after eating food, there is relief from the pain in case of duodenal ulcer. Why? Because the Brunner's gland in the duodenum were secreting base that was neutralizing the acid. Now, come here. Again, if the patient is eating again and again and feeling after eating he feels relief from the pain, he will try to eat more and more. So there will be history of weight gain associated with duodenal ulcer. I hope now you understand that. Now, treatment for both the ulcers, medical management is same. You go for the PPIs, right? Investigation of choice, you already know. There will be upper GI endoscopy you will be doing, right? And in gastric ulcer, also upper GI endoscopy, you also take out the tissue sample. Why? You send it for biopsy to rule out for malignancy, because there is high risk of adenocarcinoma in the case of gastric ulcers. Now, again, high selective virgotomy is done in case of duodenal ulcers. In gastric ulcers, you can go for Roux-en-Y surgery or Billroth 1 and 2. Now, one more thing they have asked you, most common nutritional deficiency occurring after vagotomy and gastric reconstruction. That is the iron deficiency, right? And others are B12 and D3 deficiency. Now, just leave everything and come. 3 important concepts we will be revising from biochemistry also. First, iron absorption takes place in tell me guys, where does it take place? In the duodenum or in the stomach? Please answer. Iron absorption. And acid increases the absorption of the iron or not? 2 points. After that, please answer guys. Can somebody answer? Nobody is answering. Iron absorption takes place from, yes, duodenum. Very good. Yes, very good. Now tell me something about the absorption of vitamin B12. B12 absorption is a very unique story. Yes, and acid increases iron absorption. Very good. Right. So 2 things. Duodenum, iron absorption taking place from the duodenum. Acid increases iron absorption. Very good. Important 1 point we have discussed from the biochemistry and other parts. Second important point regarding B12 absorption. See, intrinsic factor is secreted in the stomach. In the stomach, intrinsic factor is made by the parietal cells, right? This intrinsic factors comes and binds to vitamin B12 in the duodenum. Understand? Now, in the terminal ileum, there is absorption of this binded B12 with intrinsic factor, right? So absorption of B12 takes place in terminal ileum, but the intrinsic factor is secreted released in the stomach by the parietal cells. The binding of the intrinsic factor with B12 takes place in the duodenum. So B12 has a very unique story. I hope now you can remember and recall all the 3 important MCQ points from the biochemistry point of view also, right? For the B12. Now, coming here for the dumping syndrome, you have the early dumping and the late dumping, right? So what is happening in early dumping and late dumping? See, suppose a patient was not taking oral food intake for a long term, he was on a long-term parenteral nutrition, or suppose a patient with malnutrition case comes to you, or a patient with gastric resectioning surgeries, right? In all these cases, long-term oral intake is prohibited, so patient is not taking. He starts taking food after some time. What will happen? Suddenly, a malnourished patient or a patient with long-term parenteral nutrition starts taking food. If a patient takes hyperosmolar food, anything, right? So what will happen if the food has greater osmolarity than just basic chemistry? Anything that has more osmolarity will attract water. So suppose this is the lumen of the GIT. The patient takes the food suddenly, right? What is going to happen if it is hyperosmolar, more in osmolarity? Of course, it will contain sugar, glucose, everything, and sugar is always hyperosmolar. If it is hyperosmolar, it will attract water. From where? It will attract water from the surrounding intestinal tissues. Not only that, from the vessels and the blood vessels supplying the intestine, right? The lymphatic channels and everything, the interstitial fluid, they will draw water. Because the food is hyperosmolar in nature, it will draw water into the intestinal lumen. Now, since the water will come into the intestinal lumen, the bulk will increase, peristalsis will increase, and there will be increased risk of diarrhea, right? So diarrhea will be there. Now, this is called as early dumping. It happens within 20 to 30 minutes of food intake. Hyperosmolar food comes in the lumen of the intestine. It attracts water from the interstitial tissues of the intestine into the lumen, increases the bulk, diarrhea is precipitated, and there will be loss of fluid. Early dumping happening between 20 to 30 minutes of food intake. Late dumping, what is happening? Very important concept. Just think and listen very carefully. You take the food. You have taken food intake. After taking food intake, you might have studied in the medicine, right? And in the patho for regarding the blood sugar test, one you do the fasting test and another you do the PP, postprandial test, right? Fasting you are doing empty stomach, and after taking food, 2 hours after taking food, you do the PP. Can you guys remember why 2 hours after taking food? Because it is after 2 hours only the insulin released from the pancreatic beta cells reaches its peak in the blood. समझ में आ गया? Can you understand? Now try to understand and correlate the concepts. This is the reason. Now in late dumping, what is happening? You took the food, right? After the body was not getting food, oral intake was not there, NPO was there for a longer period of time. Suddenly you took food in large amount, right? You took large amount of food. It contained large amount of glucose. So what will happen? The gut will become hyperexcited. The pancreas will become hyperexcited. They will release massive amounts of insulin because there will be sudden hyperglycemia. All of a sudden, after a very long period of time, sudden hyperglycemia, pancreas, beta cells, they will release large amount of insulin. And due to release of large amount of insulin, this insulin will reach its peak action 2 hours after food intake. It will cause? It will cause reflex hypoglycemia, because insulin ka, what was the work of insulin? Work of insulin was to decrease blood glucose level. If large amount of insulin is secreted from the pancreas, it will cause reflex hypoglycemia. This is the concept behind late dumping. I hope I'm clear, guys. Now you don't need to remember these concepts. Just understand very simple concept: early dumping, late dumping. Try to remember it conceptually. Very easy. Insulin reaches its peak 2 hours after you took a lot of food, right? And hyperosmolar that was increasing, causing hyperglycemia. Reflex hypoglycemia was there, and due to reflex hypoglycemia, due to increased large amount of insulin secretion, there will be reflex hypoglycemia, and blood glucose level will ultimately come down. This is late dumping. Done. Early dumping, hyperosmolar food you took, it came in the lumen of the intestine, attracted water from the interstitial tissues, increased the bulk, the patient suffered from diarrhea immediately 20 to 30 minutes after the food intake. That is early dumping. Done. Chalo, come here. Coming here to the last of the topics. Now coming here to the carcinoma stomach, you will see what you will see, guys, in the carcinoma stomach. Generally associated with APC genes, right? And E cadherin. There is poor prognosis for both of the associations. Now, P53 association is also there. Most common carcinoma esophagus is, carcinoma stomach is adenocarcinoma. Very common. Why? Because the stomach has lining of glandular epithelium, right? Tall columnar cells, goblet cells containing goblet cells, and glandular epithelium. So, adenocarcinoma more common. Now, most common site is again the pyloric antrum in India. In the world overall, in the West, it is the proximal stomach. Distal gastric carcinoma, Lintes plastica, right? We have the Trossier sign and the virtual lymph node, right? Left supraclavicular lymph node metastasis is there in case of this, right? Irish nodules, we will see it is left axillary lymph node ka involvement. Acha, did you notice one thing? Why only left? Because very simple concept you can remember in gastric carcinoma. Stomach is present on the left side, so mostly left-sided nodes are getting involved. From the very simple trick you can remember, stomach present on the left side, left-sided nodules involved, left axillary lymph nodes, Irish nodules, Trossier sign or virtual lymph node, what will happen? Left supraclavicular lymph node metastasis. Done. Left. Now, sister Mary Joseph nodule, you can see there will be periumbilical, cutaneous metastasis will be there, right? Krukenberg tumor of ovary, nothing. It is bilateral. Ovarian metastasis, right? Where it will be seen? It will be seen in signet ring type of gastric ulcers or gastric cancer. The metastasis will be to the ovarian tissues, right? And it is called as Krukenberg tumor. You have already studied this in gynae also. Investigation of choice is again upper GI endoscopy and biopsy. Staging, you do it by CECT abdomen. Coming here, and metastasis, you always know in case of metastasis, whenever they tell you metastasis, it should be done by PET scan only. Now, come here to the carcinoma esophagus. Carcinoma esophagus, again, most common cause. Squamous cell carcinoma. Why? We already know the esophagus is lined by stratified squamous epithelium, non-keratinized type. So, if it is lined by stratified squamous epithelium, the most common carcinoma that is going to develop is squamous carcinoma. Now, most common in the Western world, adenocarcinoma. Why? Why adenocarcinoma? See, because in the lower one third of the esophagus, we have already discussed, there is formation of what? Because due to the gastric esophageal reflux disease or GERD, if there is Barrett esophagus is itself a pre-malignant condition, right? And in Barrett esophagus, what was happening? The squamous epithelium was transforming to tall columnar type of cells, right? So if there are tall columnar type of cells, what will happen? There is risk of development of, in the tall columnar cells or the glandular epithelium or the intestinal epithelium, there is more risk of development of adenocarcinoma. That is why in the Western world, since cases of GERD and Barrett esophagus is more common, you will find adenocarcinoma where? At the lower one third of the esophagus. Why lower one third? Because lower one third forms the junction with the stomach. There at the lower one third side only, there is the development of Barrett esophagus, that is transformation of the squamous epithelium of the esophagus into the columnar epithelium. I hope you can recall and understand the concept. We have discussed it very fastly. Now, coming here to the clinical features of carcinoma esophagus, I have already discussed lumen, carcinoma, cancer, tumor growth will be there. So liquid will pass easily, but the solid, whenever it will come, it will get obstructed in the lumen. Why? Because of cancer or metastatic growth or the tumor growth, right? So in carcinoma esophagus, you will get dysphagia to solids first as compared to dysphagia to liquids. Now, I hope now you will remember the concept. Investigation again is barium swallow. Rat tail appearance will be seen. Upper GI endoscopy and biopsy is done. Staging is done by abdomen. Distant metastasis use the PET scan, right? And 18-FDG tracer is used for the PET scan. Coming to GIST, gastrointestinal stromal tumors, right? Here you will find arises from the pacemaker interstitial cells of Cajal. We have already discussed, right? Now, most common site is stomach, associated with c-KIT and CD117. Both are same diagnostic markers for GIST, but most specific marker, the pathology part you have discussed here, is DOG1, right? DOG1, most specific marker for GIST, and CD117 c-KIT, right? Suppose if there is CD117 negative and or c-KIT negative, then also in those cases also the DOG1 is positive, still positive. That is why DOG1 is considered as most specific marker GIST में. Now, अब आ जाओ इधर. In the trichobezoar, you can look at the image here. Oh, we will send the PDF, don't worry. Trichobezoar, you can see image they have given. Gastric antral vascular ectasia, not very important. Just look at the image. Another important topic, current jelly-like stool. You can look at the image here. Current jelly-like stool. This is intussusception. What is happening in intussusception? Nothing. See, there is invagination of one part of the intestine into the other, one loop into the other. This is intussusception. It is also complication of rotavirus vaccine. Whenever you give, there is risk of intussusception. In intussusception, most commonly it happens in the pediatric age group. Whenever they will give you history of pediatric age group, you can understand it is for the intussusception, right? Current jelly-like stool will be present. History they will give you in pediatrics also, you might have studied. I have showed you the image also. Current jelly-like stools, right? Now have a look here. Up here again, lump will be sausage-like. Now suppose I told you two things, two important radiological questions they have asked you from intussusception. We will be discussing that. Pehla, investigation of choice, CECT abdomen, you know. Barium anemia mein what will be the sign? So claw hand sign is present. Look at the image. Why we call it claw hand sign? See, just one loop of the intestine, another loop is going in. Is it appearing like the claw of the bird, claw loop sign or claw hand sign? Just have a look here. You can look here at the claw hand sign or the claw loop sign. Another sign what you will get it. Suppose you were looked at from this cross section. If you are looking at the image from this cross section, then one loop of the intestine, another loop, one loop going into another loop. How is it appearing? It is appearing like a target sign, right? So this sign can also be present. Target sign or claw loop sign, one loop, another one loop going into another loop. I hope you will never forget now. From the intussusception concept only, you know, one loop goes into other. So claw hand sign, if you look from this cross section, if you diagnose from this cross section, one loop going in the other loop, target sign. Both the signs we have discussed, important signs, the radiological signs. In the radiology part, they have asked, history will be of pediatric age group. Intussusception also associated with rotavirus vaccines. History will be of red currant jelly like stool. Done. Investigation of choice, CECT abdomen will be there, right? Now management, nothing, hydrostatic reduction very easily. But suppose if it intussusception remained for longer period of time, right, it became gangrenous, then what you will have to do? You will have to do resection, and resectioning of the gangrenous and the dead part and the fresh ends and the vital ends, we will do end-to-end anastomosis. Coming to the Meckel's diverticulum. So in Meckel's diverticulum, only true diverticulum. Zenker's we had discussed between the thyropharyngeus muscles and the cricopharyngeus, Coelius dehiscens we had discussed, right? Coming in the midline, but the tip is diverted towards the left lateral. History of bad breath, regurgitation, dysphagia we discussed in Zenker's diverticulum, and it was false diverticulum. Why? Because only two layers were coming. Now in Meckel's diverticulum, only example of true diverticulum. All layers are involved, right? Now or MCQ point, ठीक है, patent vital intestinal duct VID, more common, one of the common cause, and it is the most common congenital disorder of the intestine. Now here just have a look. Whatever you have to do in the Meckel's diverticulum, there is a rule of 2. What is the rule of 2? 2% of the population is involved. Generally it is 2 inches long and it is 2 feet proximal to the ileocolic junction. Nothing else. Just have a look at these images for the Meckel's diverticulum. You will be able to identify, right? Images they have given you. Images in Meckel's diverticulum not very much important. Just have a look at the images. Mostly images are important for this intussusception. Now also have a look here from the illustrative diagram. You can see Meckel's diverticulum, what is happening. Again you have to do remove the section and then do the intestinal repair. Coming here to the toxic megacolon or Hirschsprung disease. In Hirschsprung disease, what is happening? Again, there is absence of ganglion cells in the Auerbach and the myentic plexus, right? So if there is absence of ganglion cells in the Auerbach and myentic plexus, what will happen? See, the rectum will be shrunken, closed, band, stenosed type ka, right? And this will the distal part, the proximal part will be dilated with the fecal matter, with the air. So colon will be enlarged. That is why it is called as megacolon, Hirschsprung disease, right? Now, what do you have to do for diagnosis? You have to cut out the full thickness of the rectum and check, because where there is absence, whether there is, the pathologist will take the section and he will check whether there is absence of myentic ganglion cells in the Auerbach plexus and myentic plexus, right? Coming to sigmoid volvulus. See, sigmoid volvulus, nothing, sigmoid colon or malrotation of the gut along with the mesenteric axis. Most commonly, it is the anti-clockwise rotation. In X-ray, very commonly they have given, asked you in radio and surgery combined question, coffee bean-like appearance, this one, sigmoid volvulus, right? And one more sign they have asked you is the bird prey sign, right? Tapered varium column, where X-ray you will find that bird beak, appearance of bird of prey sign, right? Now coming to diverticulosis, nothing, most common sigmoid colon mein, near the mesenteric border. Pain will be there in diverticulosis, pain will be in the left iliac fossa and symptom of constipation will be there. Okay, if there is present pain in the right iliac fossa, you will doubt for appendicitis, left iliac fossa, constipation, right? Signs of sigmoid, yes, signs of diverticulitis, right? Diverticulosis. Now coming here, investigation of choice will be CECT abdomen. Most management will be high fiber diet and resection and anastomosis of the damaged sections. Coming here to the some important diseases, that is the familial adenomatous polyp, FAP. In familial adenomatous polyp, you will see first they will give you history. What most common site generally is happening in the rectum. Gene association they have asked you is APC gene, chromosome 5q, right? Now familial adenomatous polyp, it is Incidence is 1 in, tell me, 10,000 live births. Male is to female, you will see equal incidence in male and female both. Familial adenomatous polyp is equally common. And now, what are the common history you will get? You will look to see a large number of adenomatous polyps present. The onset age will be early age of onset. Try to understand. And in the long run, there will be development of colon cancer. So FAP, three important things you have to remember. Multiple adenomatous polyps will be there, right? And there will be history of the polyps in the entire family. So familial, name itself familial. That means in the family, in the generations, there will be history of adenomatous polyps in the family. There will be history of development of colon cancer in the long run. In case of FAP, the gene association they have asked you is FAP, APC gene in the FAP chromosome 5q, right? Now, come here to the Peutz-Jeghler syndrome. Peutz-Jeghler syndrome also they have asked you. This is also an autosomal dominant syndrome, right? And in Peutz-Jeghler syndrome also polyps will be there. But they will write in question, the key point will be hamartomatous polyps. First key point. Or if they give you in the image, they will tell you mucocutaneous pigmentation will be there. That means pigmentation will be along the skin, right, and the mucous membrane. So mucocutaneous pigmentation will be there in the Peutz-Jeghler syndrome you will find, right? So different point you can look, and the polyps will be of hamartomatous type. Now have a look, guys. Mucocutaneous pigmentation we have discussed, right? And here also there will be this increased risk of gastrointestinal and non-gastrointestinal cancers. Just have a look at this image. Now I'll show you the mucocutaneous pigmentation. You can have a look here. If they give you in the image something like this, that the pigmentation on the skin, and they tell you the history of polyps, hamartomatous polyp, suspect for Peutz-Jeghler syndrome. Then guys, when to suspect for Peutz-Jeghler syndrome? चलो क्रॉन्स डिजीज पे आ जाओ. क्रॉन्स डिजीज पे आ जाओ. क्रॉन्स डिजीज, अल्सरेटिव कोलाइटिस. क्रॉन्स डिजीज again, and in the ulcerative colitis, what is going to happen? Two important disease. For the Crohn's disease, remember very simply, don't go into much detail, just listen. See, for Crohn's, the appearance will be cobblestone like. I hope when you were children, you might have watched the Takeshi's Castles, right? So in the cobblestone like appearance, what will happen? You will are jumping from one stone to the other, right? Now understand, cobblestone appearance, jumping from one stone to the other, indicative of skip lesions. Skip. So in Crohn's disease, the appearance will be cobblestone, the lesion will be skip lesion, and it will be transmural. Why skip lesion transmural? Involving all the layers of the wall. So like this, Crohn's disease, skip lesions, right? Cobblestone appearance and transmural lesions. Now, in the ulcerative colitis, what is going to happen? Only the mucosa and the submucosa will be affected, right? Not transmural involvement. And more common site will be rectum. P-ANCA association is there, and there will be lead pipe-like appearance. Ulcerative colitis, the lesion will be continuous. Just have a look at the lead pipe-like appearance. I will show you. This one is the lead pipe-like appearance. Now, coming to the hemorrhoids and rectal prolapse, we have two topics left. Not much, and it will be over. 3 pages are just left. So we will continue. Coming here to the hemorrhoids. So in hemorrhoids, there is dilated vascular channels. Most common cause, mostly it is bleeding per rectum, right? Now, and you will find what? Constipation will be the sign will be there, and hemorrhoids will be painful and painless. Painful when it is below the dentate line. Above the dentate line, it is painless generally, right? Location, more commonly 3 o'clock, 7 o'clock, 11 o'clock. Investigation of choice, nothing. Direct examination, visual examination via proctoscopy. You put the proctoscope in the rectum, you examine it visually, and then you can examine for the hemorrhoids. Now, coming to perianal fistula. Before going to the perianal fistula, try to understand the concept of sinus and fistula. What is sinus? Sinus is a blind tract. Any tract, blind tract, ileal lining, sinus. Fistula is a hollow pipe-like structure or a tract connecting two hollow organs, two tube-like organs. Simple, very simple concept. Fistula is just like a tube connecting two hollow tubes. Sinus is a blind tract There's a tract from a tube and it is blind. One end is closed, other end is open. Difference between sinus and fistula, I hope you understand. Now, come here to the perianal fistula. In perianal fistula, you will see the most common site, it is the intrasphincteric. Most common cause is infection. Investigation of choice is fistulogram, right? Coming to rectal prolapse, it is of two types. You have the partial thickness. In children, it is partial thickness. Adults, it is full thickness. Now, perianal management. Just come here. You have the perineal management. Then you do the Thresh repair. You do the Delorme repair. Ekdam naam, only names they have asked, right? In Dolormes, continuous sutures have been used. Altemere, perineal rectosigmoidectomy, and abdominal management, Ripstein rectopexy. Done. Only names, nothing important. Coming here to the appendicitis, more important topic, very important topic. In appendicitis, most common cause they have asked you, that is a fecal obstruction. Mantriel's score they have asked, important. But before that, we will discuss how will the appendicitis case present to you. See, the appendicitis case, they will give you in history, comes with the pain in the right iliac fossa, right? And McBurney sign will be positive, or McBurney tenderness will be there. Ropsing sign will also be positive. There will be pain in the right iliac fossa on when you press on the left iliac fossa, right? And now, see, one more thing. Obturator sign will be positive. Right iliac fossa pain will be there, right? On internal rotation of the flexed hip. Whenever you internally rotate the flexed hip, then you will feel, the patient will feel pain in the right iliac fossa. Investigation of choice for acute appendicitis is CECT abdomen, and management appendectomy. You already know. First, medically you have to manage, then finally surgical management is appendectomy. Coming here to the Mantriel's score. Mantriel's score you will see MANTRELS. M is migratory pain in the right iliac fossa, 1 point you will give. A is anorexia. Suppose and appendicitis is there, will no anorexia will be there. N is nausea, vomiting, again 1 point. T is tenderness. Tenderness is given 2 point. Why? Because it is indicative of infection. Now, rebound tenderness 1 point. Elevated temperature again 1 point. Leukocytosis again WBC is increased. Infection indicator 2 point. Right? Shift of neutrophils 1 point. Now just listen to me very carefully. Mantriel's score mein everybody is given 1 point except two things. One is the tenderness and another is the leukocytosis. Increased WBC count. Rest everyone will have 1 point. This question that can be asked. Tenderness you give 2 points. Leukocytosis you give 2 points. All others 1 point. Appendicitis done. Coming to pancreas, again acute pancreatitis, they will give you the history. Patient is having epigastric pain. On bending forward, the patient feels the pain to be relieved, relaxed. There will be history of alcohol intake, right? Or there can be history of gallstone, right? Now, come here. Some signs they will give you. What is Cullen sign? Cullen sign is periumbilical tenderness and ecchymosis and discoloration. Great Turner sign, there is flank bruising present or ecchymosis or bruising present in the flanks and discoloration. Fox sign is there. Ecchymosis over the inguinal ligament region is there, right? On abdominal X-ray, what you will see, sentinel loop sign and colon cutoff sign. Investigation of choice for pancreatitis again is CECT abdomen. And before CECT abdomen, just a minute, you also have to go for some pathological parameters or biochemical parameters, and they are serum amylase and lipase. Serum amylase lipase will be highly elevated. More specifically, serum lipase is very specific for pancreatitis, but amylase level is elevated more than 3 times, right? It is also indicative of acute pancreatitis. Now, management is ERCP. Then you do the sphincterectomy with stone resection by Dormia basket. Coming to chronic pancreatitis, most common cause here is chronic heavy alcohol use, right? Pancreatic ductal cystic fibrosis. Now, MRCP, ERCP, you will find they will give you classic chain of lake appearance. This is not very frequently asked, but yes, we have discussed. Surgery, longitudinal obstruction of, if there is longitudinal obstruction, pancreatico-jejunostomy you have to do. Coming to the liver. Liver segments, how will you remember? Just see, they have asked you the segments of liver. Draw 3 lines, and now I will tell you how to remember the segments of the liver. First segment, it is not visualized in the 2D image whenever you are seeing the image liver from the front. Now see, start from the 2, then move 3, then you have 4A and you have 4B. 2, 3, 4A, 4B. Done. For this one, remaining segments, जैसे ही you do this, after that you have to look at other segments. Just go with, you have the 5, then you have the 6, you have to move in clockwise direction, 5 6, then you have the 7, and then you have the 8. Then 5 5 6 7 8. अंडरस्टूड. पहला क्या है, 2 3 4A 4B नॉर्मल सीक्वेंस में. अपार्ट फ्रॉम द सेगमेंट 5 5, then you have the 6, just move in the clockwise direction, 5 6 7 and 8. Now different abscesses, integrating micro and everything we will discuss here itself. चलो आ जाओ. So first we will discussing about the pyogenic abscess, then the amoebic and the hydrated liver abscess. आ जाओ. Or hydrated cyst. Now see here, pyogenic abscess, it is happening due to streptococcus, you know, E. coli infection can be there. Now pyogenic abscess, bacterial infection abscess, common features, fevers, high fever, chills, jaundice. Khatam. Diagnosis में what will you do? You will do the USG abdomen, LFT you will do, and investigation of choice CCT abdomen. Khatam. Now since this is abscess, pus collection is there, you will have to send the pus for culture. So pus culture investigation you will do. Now bacterial infection, antibiotics, normal cephalosporins, aminoglycoside, metronidazole, all these, right? Now abscess is there, you will have to do incision drainage or drain the pus. For drainage, so percutaneous catheter drainage you will perform. Coming to Entamoeba histolytica, it is a protozoa, gastrointestinal protozoa, right? Amoebic in nature. Now what you will see, it will again abscess is there, the fever and chills, right? Now USG में same investigation, same. Now classical features for Entamoeba histolytica, microbiology we might have studied, anchovy sauce like appearance and flask shaped ulcers, right? Flask shaped ulcers and anchovy sauce like appearance, whenever they give you, these are the classical indicators and keywords for Entamoeba histolytica induced, right? Yeah, abscess. Now treatment, nothing, metronidazole, right? And you will just do the USG guided catheter drainage. Again abscess is there, you have to drain it. Coming to the hydrated cyst. Hydrated cyst, what is there? Classical signs, echinococcus granulosus. Echinococcus granulosus, you know, right? History of dog and sheep, jahan dog and sheep aaya, right? Life cycle, microbiology, can you correlate? If they give you, just correlate, it will be echinococcus granulosus. Now that will lead to hydrated cyst. In hydrated cyst, what is happening? Again abdomen, ultrasound scan, and CCT abdomen you do. What is the classical sign that you see? One classical sign that appears is water lily sign seen in the hydrated cyst. You see here, it is the image of the USG. You can see the water lily sign in the ultrasound. Now one thing, in hydrated cyst, one important thing is there, that FNSC is contraindicated. Why? Because once you puncture the cyst, the fluids leak into the other part, abdominal part, and the liver part, other part, it can cause anaphylactic reaction. So FNSC is contraindicated. Now in hydrated cyst, you do the PAIR procedure. Microbiology I'm recalling, and surgery, just listen to me very carefully. PAIR procedure, PAIR. P is puncture, right? A is aspiration. I is again inject 95 to 98% pure alcohol and then re-aspirate the alcohol, right? Done. So you do the PAIR procedure, PAIR, and FNSC is contraindicated. Why it is contraindicated? Because it can cause anaphylaxis, right? Now so for FNSC, what we have done, we have discussed contraindicated. Why? Anaphylaxis का risk है. अब आ जाओ. Done. Discussed with the hydrated cyst, water lily appearance we have discussed. Coming here for the important scoring patterns, some important scoring patterns they have asked you. They have asked you about the MELD score and the PELD score, right? Liver में both are done for liver transplantation. They have not asked you the score entirely. They have just asked you the parameters discussed. So parameter is bilirubin, INR, and creatinine. In the MELD, in the PELD, it will be albumin. Okay. In the MELD, bilirubin, INR, both is same. In MELD and PELD, they are done for liver transplantation. MELD and PELD both, bilirubin and INR are same, but creatinine will be extra in the MELD, and in PELD, albumin will be extra parameter. Done. Another important, December 2022, they had asked about the child per classification. They did not ask about the scoring and all. They just asked you what are the parameters included in child per classification. Something this kind of question was there, right? So you just have to look for the parameters used. And when is child per classification done? Child per classification is done when there is liver cirrhosis, right? And for survival rate and determination and intervention, right? So determination whether the patient will survive, he will not survive, and for regarding the intervention, you do the child per classification. Suppose, look here, the parameters here involved are bilirubin, albumin, right? Then you do look for the ascites, INR, and asterixis. Khatam. The parameters involved we have done. Coming to the hepatocellular carcinoma. Most common malignant tumor of liver is, you can see the hepatocellular carcinoma, right? Primary tumor originating in the liver is hepatocellular carcinoma. But in general, if there is a tumor in the liver, it will come, most commonly it comes from metastasis. Suppose I ask you overall most common malignancy of the liver, it is due to metastasis, right? Overall primary malignancy originating in the liver itself, then your answer will be hepatocellular carcinoma. Done. Investigation of choices, triplet CT scan, marker, AFP, PIVCA2, done. Coming to the gallbladder. This is the last topic, I think, and after that we will just finish. Yes. So last topic, we will be doing it. Come here. So in gallbladder, biliary atresia. Before biliary atresia, I hope we can recall the entire biliary tree what I had taught you. अभी थोड़ी देर पहले ही बताया था. Now see, you have the liver, right? Let me draw it once again so that will be clear. Now have a look here. You have here the liver, right and the left hepatic ducts. Common hepatic duct is coming. Then you have the gallbladder. From the gallbladder originates the cystic duct. Together form the common bile duct. Now this bile duct comes here. You have the pancreas. In the pancreas you have the pancreatic duct, and it opens via sphincter of Oddi into the duodenum. Right? Now just see, in any part, biliary atresia is nothing. It is absence of biliary channels. Suppose biliary channel obstructed at different levels, it will cause biliary atresia. Now what will happen? In type 1 biliary atresia, what is happening? Common bile duct is absent. So what is the common bile duct? This one will be absent. Simple, very simple. Just try to understand. Look at the image. Common bile duct is absent. Now type 2, what is going to happen? Destruction at the level of common hepatic duct. So this common hepatic duct is this one. So destruction at this level is type 2, right? Type 3, what is going to happen? Absent right, left hepatic duct, CHD and CBD, all are absent, right? Right and left hepatic duct absent, common hepatic duct absent, common bile duct absent, type 3, done. Investigation of choice for biliary atresia, it is the HEDA scan, right? Now, treatment is Kasai operation, for the type 2 and type 3. And for type 1 biliary atresia, the treatment is hepaticojejunostomy, Roux-en-Y hepaticojejunostomy, done. Type 1, Roux-en-Y hepaticojejunostomy, 2 and 3, Kasai operation, done. Just remember the one-liner name, it is enough. Coming to choledochal cyst, nothing. Cystic dilatation of the biliary channel, right, is choledochal cyst. Clinical features, since it is a cyst, there will be lump, there will be jaundice, pain, and risk of cholangiocarcinoma will increase many folds. Todani classification is there, which we have to discuss, right? Do not need to remember everything. Have a look at the image. Only 3 important we were doing. Type 1 is the most common. Type 3, choledochal cyst, Todani classification is done. Type 1 most common. Type 3, dilatation of intraduodenal portion of the CBD. In type 5, dilatation of any intrahepatic biliary tree, right? Investigation of choice is MRCP, done. Coming to acute cholecystitis, very important. Acute cholecystitis. Inflammation. Itis means inflammation. There is inflammation of the biliary tract anywhere. Acute inflammation, route. Cause can be either stone or trauma or any infection, right? So if it is acute cholecystitis, what can be there? Murphy's sign will be positive. In the history, they will give you Murphy's sign is positive. Fever will be there and leukocytosis, WBC count will be increased. Investigation of choice, always acute cholecystitis, it is USG, ultrasonography. Now, best HIDA scan we know because it helps in differentiating whether the cholecystitis is because of stone, gallstone, that is calculus cause, or non-calculus or acalculus cause, right? Or without a stone. Now, treatment, what do you do? In treatment, you just do the laparoscopic cholecystectomy. You cut the gallbladder and remove it. Now, you can see here Mercedes-Benz sign that is being shown in the image. Now coming to the Charcot stride. Very important. They have asked you a lot of time for cholecystitis. Stride is Charcot stride. It is nothing but a triad of fever, pain, and jaundice. Simple. Bile tract is involved. Into pain will be there. Fever will be there, obviously. And since biliary tract is inflamed, obstructed, there will be jaundice. Right? And now, Raynaud's pentad. Nothing. Along with the Charcot stride, if there is due to obstruction, sometimes there can be septic shock and altered, and due to septic shock and altered mental status, that is not pentoid. Nothing else. Septic shock and altered mental status combined with the Charcot stride becomes the Raynaud's pentad. And thus we have completed the surgery revision. And now, guys, you guys can recall and remember this notes was, I think we have covered almost all of the topic. One topic is left, that is hernia. I will discuss right now that also. Okay, and I think that will be important, right? So for the hernia topic, first of all, direct and indirect abdominal hernia. We will be revising right now here only. Last topic which we are going to revise and recall. Just listen to me very carefully. See, you have the inguinal ligament. You have the rectus abdominis muscle. Then you have a inferior epigastric artery. Just have a look. This is your rectus abdominis muscle. This is the inferior epigastric artery. Right? Now, have a look, guys. I'm going to tell you about hernia. See, now look at here at the triangle. Suppose if the hernia is coming at what side? Medial to the inferior epigastric artery, it is, tell me guys, direct or indirect? It is direct inguinal hernia. Pehla MCQ point that they have asked you, medial to the inferior epigastric artery is the direct inguinal hernia. Also, it is associated with a triangle called as the Hasselbalch triangle. You can see the triangular area shaded in blue. This is the Hasselbalch triangle. Right? Hasselbalch triangle. So 3 important points associated. Now you can understand direct inguinal hernia associated with medial to the inferior epigastric artery and associated with Hasselbalch triangle. Yeah. Now, here itself you can see, or look from the another color I will indicate. This is your inguinal canal. Okay? Superficial inguinal ring and deep inguinal ring and superficial inguinal ring. Right? From the inguinal canal comes the contents. Right, guys? Am I correct, guys? Just tell me, guys. Chalo. Can we move ahead? Just a minute, guys. Somebody is saying something. So now should we start, guys? Is it okay now? Somebody audio video clear? Chalo, pencil battery is down a little bit. I will have to take a little bit time. Now just have a look, guys. Now inferior, you have seen the canal. Suppose, see here, from the deep inguinal ring is generally it is oval in shape, right? The superficial inguinal ring is triangular in shape. From the deep inguinal ring, if the intestinal loop or abdominal loop comes out, that is going to be indirect inguinal hernia. Okay, fine. From the deep inguinal ring, the indirect inguinal hernia is associated. Just see here. This one is your deep inguinal ring, and you have the indirect inguinal hernia associated. Done. Now what you will see here, you have the opening and the indirect inguinal hernia. One more question point they have asked you, is associated with opening in fascia transversalis. Right? Now just have a look. Discussed all important points from the indirect inguinal hernia. From the direct inguinal hernia, it is generally associated with Hasselbalch triangle, medial to the epigastric triangle, inferior epigastric artery, and indirect inguinal hernia is lateral to the inferior epigastric artery. Now hernia repair surgeries we already know, right? And the processes, inlay, onlay, sublay process, I hope you guys remember that, or yes. And most of the topics and points we have revised. One thing that is again we have revised, and I hope we have covered almost everything in a short span of time, nearly 3 hours 15 minutes. And I took help from the available notes because in short time we had to conclude. We took notes and different notes, compiled them, combined them, corrected, put a lot of different stuff such as scoring and all, everything and others we have added as well and improved. And from those we were trying to just try to complete the entire topic and the subject. So I hope we have completed our mission of giving you free revisions, and it is really like just for the community of our FMGs and our students. It was just like a help, and I hope that I succeed in that. And thank you guys. Thanks a lot. Scores and everything we have compiled, corrected, edited, and added a lot of things. And I hope we have covered almost all of the important PYTs. Even if you finish these notes are very much helpful.